Well, good afternoon, everybody, and welcome to our event. My name is Stephen Lewis. I have an affiliation with the O'Brien Institute for Public Health and have been loosely affiliated with the U of C since 2000, so I have a number of friends in the room. I live in Saskatoon. I think they asked me to be the moderator because Saskatchewan figured out this patient-centered stuff 15 years ago, so we're perfect. And actually, I'm here on reconnaissance to learn how to do it from Alberta. As you can see, from those of you in this very full room and the next room and apparently the atrium, this event has touched a nerve. About close to 500 people will be participating in this event, which greatly exceeded the planners' expectations, hence the room not quite big enough here, but we do have audio-visual solutions to this. Apologies to those of you who couldn't get into the room, and I hope it works out well remotely. We have a very full agenda this afternoon, and I'm not going to take up much of your time going through it, but we have a combination of digital stories, personal journeys of people, and we really thank those who agreed to have their stories committed to film and audio because they're very compelling. We have speakers who represent very strongly the public and patient voice, as well as some renowned experts in the field. And then we will conclude with an hour panel where your voice will be heard again. We're going to ask you for a little bit of patience. The interactive part won't be until the end, except we do have digital interactions all the way through, and you will see the instructions about the Twitter feed and so forth. And please do take the opportunity to raise your issues and questions. If they can't be addressed directly in the conference, they will be followed up on after, because this is a beginning, it is not an end, it is not a single event. It's the first step on the road to a very long and we hope successful journey to create a truly patient-centered care system. So without further ado, it's my pleasure to introduce the Dean of Medicine, Dr. John Meddings. It says here that Dr. Meddings began his first term as Dean of Medicine in July 12, which is optimistic, John, which implies there may be a second, which in the deanery is pretty good. So obviously you're doing all right so far. I'm not going to read all of his accomplishments, but he's been the head of the Division of Gastroenterology. He was the interim vice president of research at the University of Calgary. He has been honored with several awards and distinctions for his research innovation in celiac disease, inflammatory bowel disease, and bowel permeability. Please welcome Dr. John Meddings.
So thank you, Stephen, very much. It's a delight to be here, and as Stephen pointed out, I'm a gastroenterologist, so digital stories, I think, are something that appeals to me. You got it. So I'd like to welcome you all 450 people, to the Cumming School of Medicine in the University of Calgary. It's an honor to have you here, actually, a true honor, because today we're going to talk about patient-centered care. And I thought you might actually wonder why we're doing that in a medical school. And so one of the sayings we actually have in the Cumming School of Medicine is that our product is healthcare, our strength is people. And what does that mean? I mean, what does it mean that our product is healthcare? And so at one level, I think it's perfectly obvious. We train physicians, we train medical students, we train the next generation of physicians that come forward. But we actually do much, much more than that, and it's much more important than that. As a medical school, we have our foot in two worlds. Many of us, practice medicine within the healthcare system, and our other foot is stuck in the academic system, in the university system, a research-intensive system. And what that means is that one of our obligations is to create new knowledge about the disease and the areas we're interested in. In that case, it's medicine. So we study the causation of diseases, we study how to treat diseases, but we also study our systems by which we treat disease, things like the healthcare system. So in order to do that, in order to create strong evidence upon which policymakers can make strong policy that helps all of us, the very first thing we have to start with is questions. And that's what we're going to do today. So within the Cumming School of Medicine, we have a group of extremely talented physicians and researchers who study the health system. And they provide evidence about how we compare as a health system to other systems in the world. I think okay, we're back. Where we do it better than other people in the world, and where perhaps we don't do it as well as we should do it. And this is the O'Brien Institute of Public Health, which is the sponsor for this particular conference. So the O'Brien Institute of Public Health, I'm very proud to say, actually has taken on this challenge of looking at patient-centered care. So before going anywhere further on that, I just want to mention how we got here. How did we get to this conference? This one. How did we get to today? What started this? I don't think this is much better, so I'll speak a little louder and hope that people can, I'm not sure I'm going to reach the far rooms. But how did we get here today? And what I wanted to tell you is it actually all started with an interaction with somebody from our community. And one of the things we pride ourselves on here is working with people in our community. And this actually all started with a conversation with Charlie Fisher. And you're going to meet Charlie a little bit later. Charlie had had some difficult experiences with our healthcare system some time ago. And we had a conversation about some of those difficult decisions. And as we went through the conversation, it became obvious that we needed to involve a few other people. And so Ward Flemons and Bill Galley, two wonderful people who you're going to meet today, started the conversation along with us. And one of the outcomes of that was a decision that we needed to have a conference on patient-centered care to start a conversation about where we go with this. So the next speaker you're going to hear is Bill Galley. And I'll just take a very brief time just to introduce Bill, who's going to introduce the Imagine project. Bill is the scientific director, the founding director of the O'Brien Institute of Public Health. He's an amazing researcher, one of our most accomplished researchers in the Cummings School of Medicine. He's held a Canada Research Chair in Health Services Research. He's not only a talented researcher, he's a talented general internist, does wonderful things in the hospital. But before Bill comes up to speak, we're going to show Charlie's story first by video. So if we can have that, please.
My journey in Alberta's health system began on April 9th, 2014, when I learned that I had stage 4 throat cancer caused by HPV. What started as a minor sore throat was about to change my life. My friends helped me find an ENT specialist who examined me and gave me the news. He had taken a biopsy to confirm his diagnosis, and despite requesting the pathology on a rush basis, it took 9 days to get the results, which he needed to finalize the referrals to the oncologists. While waiting to see the oncologists, I had my family doctor arrange for a number of tests to ensure that I could rule out other primary cancer sources. That done, I thought I would move quickly to treatment. Unfortunately, I needed a PET scan and then found out I needed to get a tooth extracted before I could begin treatment. The wait for this PET scan was 3 weeks, and the tooth extraction added another 11 days. All of this could have been coordinated differently, but with delays, I started treatment on May 26th. When I asked the doctors whether it was important to start treatment as quickly as possible, they said it is, but a week delay won't matter. When I asked if a month could make a difference, they agreed it could make a big difference. My response was that each person in the chain thought that they had a week, but when all the delays were added up, they delayed the treatment by at least 2 weeks and maybe more. My experience in business is that you do as many things as you can at the same time to get to the desired state as quickly as possible. But I found myself stuck in this frustrating linear system. In the end, I have had a very positive outcome. As a person with resources and capabilities, I pushed the system to be nonlinear, like the time I pursued getting IV at home on weekends. I accessed an EMS program that had never been offered or used by Tom Baker. I initiated additional monitoring and support, including strength training and acupuncture, which were outside of the usual protocols. I had excellent providers who developed a successful treatment plan, and I am very appreciative of their skills. That said, my providers thought their responsibility ended when they followed the protocols. However, I took responsibility for my own needs with the help of family and friends, and I believe this minimized the long-term side effects of treatment. To this day, I wonder what happens to people who aren't able to advocate for themselves.
Hello everyone. So as John said, thank you, John, for the introduction. My name is Bill Galley. I'm the Scientific Director of the O'Brien Institute. And on behalf of the O'Brien Institute leadership and team, I'd like to welcome you all to today's event. I'd like to thank Charlie for the opening digital story, and more importantly, for the impetus for beginning what we're calling the Imagine Project, which is being launched today through a symposium and then being developed as a longitudinal program where we are going to try to seek multi-stakeholder involvement in a provincial conversation around innovation in healthcare. The O'Brien Institute is one of the newer institutes at the University of Calgary. The Cummings School of Medicine has 7 health research institutes, and we launched officially as an institute in 2010, and were announced as the new O'Brien Institute for Public Health, named such because of a naming donation by friends of the faculty and the academic establishment, David and Gail O'Brien. Our vision as an institute is to produce better health in healthcare, and we're trying to do this through a combination of research and innovation activities that are done to some degree in a traditional paradigm of university-based research, but more importantly, what we're trying to do is broker partnerships with the healthcare system so that we can begin to convene stakeholders around shared goals, shared challenges, and ultimately shared solutions. And that preamble about the Institute brings us to today, because today what we're trying to focus on is the shared challenge of the patient and family experience in healthcare. And the digital story that you just heard is an example of a patient experience. Whenever you hear one voice like that, we know that there are thousands who have the same sort of experience. And those voices tell us that we do need innovation in healthcare. We do need new approaches. And in relation to the Imagine Project, we're interested in producing citizen engagement in healthcare planning. And today, I think you see that beginning to take shape through dialogue. We want to have a lens on patient-centered healthcare. And we want to answer some questions over the longitudinal process that we're undertaking. And some of the initial questions are pretty basic ones, although they're probably not straightforward in terms of answering. One is, what is it exactly that we're talking about when we talk about patient-centered healthcare? What do we need to do as citizens, as healthcare providers, as health system planners, as governments to get there, to produce patient-centered care? And can we imagine a new state that really is transformative? And that's where the notion of the Imagine Project comes. I have been involved in some longitudinal conversations around this topic, and many of you who know me know that I tend to stand up and make goofy jokes, and some of you who know me have heard the jokes over and over again. So, but today I actually don't really, I don't want to begin with my usual levity, because I think you will find that today's conversations will not be easy. We have had a longitudinal planning process that has involved our chair, Ward Flemons, who's sitting in the second row to my right, a group of citizens named Citizens Impacting Healthcare in Alberta, who have been part of the planning committee, tremendous new friends and colleagues. And through the longitudinal discussions, and Charlie obviously catalyzing all of this, we've heard tough stories, and they're not light, and they're upsetting, actually, and sometimes they're challenging. I'm a physician, and I hear the stories, and I know that some of the problems are cultural problems that we need to focus on and change. We want to set this up as a discussion that's disarming. We don't want finger pointing. We don't want a heat lamp on leaders in healthcare. We just want to listen and focus on the voices. What are the voices telling us? And we want to learn from other jurisdictions, and we have an exciting lineup of visiting speakers who are really, I think, going to give us perspectives. And I think this first phase of Imagine is a listening, understanding, looking outside of Alberta at ideas, and then beginning to think about ways forward for us as a jurisdiction that has many advantages, despite the price of oil, many opportunities. So just in closing, I'll say we are all citizens. So I'm a physician, but I'm also a citizen. We're also all patients, and we're all family members. So we know what we're talking about today. And some of us in this room are also health system decision makers that have the daunting, I would even say terrifying task of creating a healthcare system for the citizens of this province. So those are the realities. Today, let's listen to each other, let's listen to each other's voices, and let's imagine. I will be introducing I'm going to introduce our speaker, and then our first visiting speaker, and then we'll go to a second digital story. The first visiting speaker that we have is a very well-known one, and I believe a big reason why we're in 3 theaters today. Dr. Brian Goldman. Dr. Brian is going to be speaking about the all-too-common patient experience, and many of you know Brian as the host of CBC Radio's White Coat, Black Art. Tremendous program that I love listening to, not because it's easy to listen to, it's challenging. Some people say Brian is too critical of doctors, but he is a doctor, so he's obviously being introspective. I don't think you're too critical of doctors. I think you challenge us to think outside the box. Brian has a traditional bio, but I'll just say that one of the big reasons that we were able to invite him was that he was a med school classmate of the Associate Scientific Director of the Institute, Lynn McIntyre. We haven't asked them what year that was in, but we have asked them to tell us stories about each other way back when they were young med students. We know that Brian is an outstanding speaker. He's written 2 books, one entitled The Secret Language of Doctors, which I find to be a very fascinating book. We see him on TV, on the CBC News, and in a number of other places. He's truly an educator. He's the type of physician who has a reach that goes so far because of his meta presence in our lives. We hear his voice all the time. And Brian, we'll look forward to hearing your presentation on the all-too-common patient experience. With that, I'll end. I'll thank you all for being here. I will have a chance at the very end of the day to say a few closing words on behalf of the O'Brien Institute. Welcome, listen to the voices, and let's imagine.
As I look over the past year, one quote from an obviously frustrated MD runs through my mind. I'm a doctor, not a healer. What do you expect from me? I was confused and angry, but I didn't say anything in response. By way of background, I was a successful mid-50s senior executive who loved work and the outdoors along with my wife and 3 children. But all that ended suddenly. I slipped on ice, severed my left patellar tendon walking in my backyard. The ambulance crew responded quickly, emergency care in Canmore was efficient, and surgery at Rocky View Hospital was within 24 hours. Pretty good so far. The system responded well. Over the following weeks, however, things began to fall apart as mobility didn't return on schedule and pain did not recede as per the protocols. I was told to try harder at physio and take more Advil, so I did. An ultrasound after 3 months discovered blood clots from groin to ankle. Daily heparin shots for 5 months followed, with no drug plan. An MRI paid for by myself showed deteriorating knee strength. Again, I was told to work harder, so I did. Trips to emerge from variable pain, more x-rays, ultrasounds, and bone scans showed extensive atrophy and osteopenia. More drugs. At this point, I was almost ready to give up, and the family fabric started to fray as things seemed to be going backwards. Depression, no sleep, a loss of 35 pounds. Not good. More drugs helped, but my support circle were the key. In September, we finally pushed back, and hard. We assembled our own team to overcome the depression, manage the pain, and relearn to walk from almost ground zero. Today I've been cane-free for 3 weeks, and most of the drugs are gone. So I am slowly getting better due to huge personal support, the ability to pay for private services, and an enormous cost to the system. Why was it so hard, as it wasn't that unique an injury? And what about someone who didn't have my resources or support? I often think of the 80-year-old widow with a broken hip with whom I had shared a room. She had no one to go home to, no support fixtures in her house, and no money fill in the blanks. How did she manage? I've also had time to think about how I might have responded to that doctor. I am a patient. I am scared, desperate, and in pain. I expect the system to understand that.
Is not only, yep, we're on, the articulate, yeah, I actually did, I saw the little green light, so it was on. There's going to be a lot of mea culpas today, so we'll see if I can handle the AV. First of all, I'm thrilled to be here. Second, how do I follow stories like that and the stories that will follow? Well, the most important one has already been said by Bill, just listen. And we have such difficulty listening, and I'm going to talk a little bit about that. I'm going to expand on it in a little bit more detail and hopefully leave a few messages at the end, something to think about to set the table for today, and then I'll be happy to participate in the discussion at the end of the day. The year was 1980. That was the year that we graduated. If I'm not going to be honest, then I shouldn't be standing in front of you, right? And I remember nothing about Dr. McIntyre except that she was a brilliant and young medical mind who was going to go places, and she obviously did. Now me, the only thing they said about Brian Goldman is that he would study for a blood test. All right. Oh, this works. Good. Okay, so one of the things, you know, I think that if you've listened, I did a TED Talk talking about my own mistakes, and I could go down that road, but to do something a little bit different, I want to talk a little bit about the culture of medicine and what I think is one of the common threads that makes it so difficult for us to, as healthcare providers, to listen. And it has to do with that little problem of empathy. And if you've lost your empathy mojo, I'll talk a little bit about why. Some of the system issues, some of the technological issues, what the cost of that is, and what we can do about it through patient engagement and a couple of other things, some transparency, which is a very clear message that I'm hearing that people want to hear about. And try to wrap this up and leave plenty of time for everybody else. Now, Bill, I was told, well, we're going to have a serious day and we're going to hear some serious things. I hope that we can have, if not levity, then some satire. And I want to play, in a moment, I'll get our folks on the other side of the glass to turn on the the video. I just want you to watch this. This is a wicked parody from a show called Little Britain, and it's a not uncommon kind of encounter between a mother and daughter and the first person that they meet in the hospital who's there to clerk them in, as it is. Have a listen.
The British pride themselves on being the rudest, most unhelpful people in the world. Receptionist Carol Beer is working at this hospital in Pennsylvania.
Hello. This is my daughter. She's a big, brave girl, and she's going to have an operation today.
Name?
Tell the nice lady your name.
Danielle.
Danielle what?
Danielle Lloyd.
Age?
Nearly 6.
You're 5.
Yes.
We'll say 5 then. Address? Where do you live?
With Mommy and Daddy.
1772 Lincoln Road.
We got there. Putting your details in now.
Danielle's going to have her tonsils removed.
I've got her down for a double hip replacement.
Oh, no, well, there must be some kind of mistake.
Computer says no.
Well, that must be some other Danielle Lloyd.
Computer says no. There's only one Danielle Lloyd on the system. Do you want the double hip replacement or not?
All right, I think we've heard enough of that. One of the things now, of course, this is, you can say it's a parody, it's satire, but what's the definition of satire? The best definition I ever heard was a bitter pill with a sugar coating. And if I could, I mean, we could spend the next hour, the next day dissecting what it was about that encounter. But right from the very first greeting or lack of greeting, how many of you find that you can go an entire day or an entire shift without smiling? Oh, come on. Come on. You know, as if your smiles are revelations of inner turmoil, or they are, or they're, you know, they cost $1,000 each. It's the cheapest, easiest thing that you can do. It's good for your health, and it will be good for your patient's health. You have no idea. When patients and families see you smile and look like you've got all the time in the world, even if you don't, it can make a huge difference. Now, that story was the satire. I'm going to play some real tape now. I had the extraordinary opportunity to watch the fledgling patient engagement program at Kingston General Hospital. And what you have there is a group of, it's an interdisciplinary group. You've got Chris Simpson over there, who's now the president of the CMA. You've also got a whole group of patients and families. All of these people have one thing in common. They all work for free at the hospital as patient experience advisors. They are all former patients, former family members of patients, or family members of former patients, and they all have a common denominator. They all came to the table with stories to tell. And I want you to hear the first one from Ellen Batter, who's a patient experience advisor, has been now for 4 years. She's on the emergency subcommittee. She is the spouse of a man with Alzheimer's disease, and described the experience of being that family member every time she registered her husband who needed medical care. Let's hear that tape.
I was amazed at the lack of communication in the emergency department. By the time my husband, on one occasion, by the time we were in and out of there, I had to inform 7 people that he had dementia. The message never got passed on, and I had to talk about his dementia in front of him. It was very demeaning. I think I just had the general feeling that we were dismissed, and that you have a special connection with your spouse when your spouse has a dementia, and you don't want to speak for them, but you need to supplement that, and so I was never spoken to. It was just not pleasant.
And this is not the story of a disaster. So you don't have to have a disaster or a series of horrible medical errors. And some of the things that you're going to hear about fall into that category. It can be as simple as not receiving empathy. Inefficient systems that seem more in service of the people who are running the system than the people they serve. One of the most articulate patient experience advisors I met there was Jennifer D. Jennifer D. Has had many experiences in the healthcare system, but she's going to describe one in which she was a patient who had just received a double knee replacement for osteoarthritis. Go ahead.
A lot of the people around the table initially at the advisory council did not experience that, and I have a multitude of experiences to speak about that are negative, but I'll just pick one. As a non-ambulatory patient on an orthopedic ward, I was in a bed. I was dependent on the people at the nursing station for every single thing that I would get throughout the day and the night.
You had a couple of knees replaced, didn't you?
Good guess, Dr. Goldman. So I rang the buzzer, and of course I was on IV and getting lots of fluids. They were coming in, and surprise, they were also going out. I said I need to use a bedpan. The nurse brought me a bedpan and left me. She came back about 20 minutes later, and I said, "I'm sorry, it's very full. You might want to use 2 hands." She said to me, "I know what I'm doing." She yanked it out, dumped it in the entire contents in my bed, grabbed some blue pads that I know that you're familiar with, stuck them under me, and I stayed there for the remainder of the night while they had a birthday party at the nursing station. I'm not shy and I'm not retiring. I'm reasonably well spoken. What would someone with less capacity do? And I was dependent on her for all my pain meds. Do you honestly think that I would complain to her when my pain was already not being controlled? Where was my voice? I couldn't exercise my voice. I had no one to advocate for me.
And she wonders who would advocate for someone who couldn't advocate for themselves, which is something we've already heard. So, I can talk about a lot of problems, but I want to focus on what I think is the root problem, and that is a gap in empathy. And that's I don't know if I have a definition. I don't have it here. I mean, there are many definitions that I've heard: sympathy, feeling the same thing that somebody is feeling, or expressing sympathy, somebody who expresses sympathy. Sometimes I've heard sympathy described as empathy or sympathy for a person who is in a deep pit of despair. And the person who's expressing sympathy is at the top, at the edge, looking down and saying, I'm sorry for your loss, or I'm sorry for your, for your situation. Whereas empathy is the ability to put yourself in the place of the person with whom you're empathizing. And the metaphor would be, instead of standing at the top of the pit looking down and expressing nice thoughts, you're actually standing right beside the person in the pit saying, I know how tough it's going to be to get out of this because I've been there. And maybe on your better days, maybe we can do that together. Or maybe I can help you. I don't think there's a lot of either, but there's a lot more of I'm sorry for your loss than this ability to put yourself in the position, in the place of your patient. And I want to talk for a few moments about some of the roots of that. I mean, certainly a lot of us in healthcare believe that empathy is a personality trait. And in other words, you either have it or you don't. I'm not an empathetic sort of guy. And actually that's not correct. And I'll present a little bit of evidence later to show you that we're hardwired to empathize. We all empathize. But culture and training trains it out of us. I think that a lot of us in healthcare these days tend to fear that if we become empathetic, if we demonstrate empathy, that a 5 or 8 or a 10-minute appointment is going to spiral into 35 or 40 minutes, and that there'll be an insatiable demand. Once you're empathetic, you need to be empathetic all the time. How can I live up to that ideal? I think that the root cause for many of us is that we haven't received training. We don't know how to empathize. We don't know how to give an empathic response, and simply because we haven't been taught. I also believe in the culture of medicine that some of us believe empathy is a soft skill, something that you offer when your diagnostic skills are lacking. You know, be an empathetic person so when you make mistakes you won't get sued. I think. Why is it that family doctors are less likely to get sued than specialists? And you know, if you listen on the ground of the culture of medicine, that's the kind of thing that you hear. There are other reasons. There's no question to me that technology is a double-edged sword. Technology is a wonderful thing. If you think of the ability to use technology to gather information quickly that would have taken weeks to gather or even months to gather in the past, and many, many trips to the library. Best practices can be shared almost immediately. You might actually end up with legible clinic notes. But there are other things that are part and parcel of technology that I think could be getting in the way of empathy. One of them is that infernal screen in the clinic. And how much time does the healthcare provider spend looking at the screen instead of listening to the patient? And I would also say, cut them some slack. How much time do they have to spend in front of that screen because the system demands that they follow rules, that they do things in a counterintuitive way to enter data in a way that is actually so much more difficult than it used to be with paper and pencil or paper and pen. And yet we are slaves to that technology. We are slaves to the latest software, and I can't tell you how often it happens. And there's a message in that the system is not particularly empathetic to healthcare professionals. So is it surprising that at times they're not that empathetic to patients and families? System factors. Back in 1984, when I started working at Mount Sinai Hospital, we saw 70 patients a day. I think there were 3 shifts, 7 a.m. to 3, 3 to 11, 11 to 7. Weekends, there were 2 shifts, 7 a.m. to 7 p.m., 7 p.m. to 7 a.m. Today, closing in on 70,000 patients. We have quadruple coverage now in many, many times in the day. We have patients who are older, who are more complex, who have more needs. There are more expectations. Social media, mainstream media is constantly talking about how we're overpaid, and now they're starting to talk a lot about the mistakes that we make. We're all suffering from what economists call productivity pressure, and I need to nod to that as well. Productivity pressure meaning we're constantly being asked through the use of technology, through patient volume, through patient complexity, to do more as quickly as possible. And that gives us an almost constant sense of time pressure that I think often reflects on the way that we are with patients. And I want to say a little bit about this. I said this on a column last week. Where did we get the idea that a 10-minute appointment is enough? Where did that come from? It kind of evolved. It evolved from the fee schedule, whether it's fee for service, and I know that many provinces, most provinces are doing their best to do away with fee for service. And the idea that healthcare providers don't get paid to innovate, don't get paid to do something creative, to do something different. And what I took from Pierre's story, for instance, was finding ways to go around the system. Well, the system doesn't reward people who do that enough. And one of the things you're going to have to get your brains around if you want to make the Imagine project really take off is to find ways of knowing when to standardize and when to customize. And to break some of those rules that get in the way of customization in favor of standardization. As a result, though, we figure out ways of making a living, whether it's fee-for-service or capitation or alternative funding plans. We figure out what we get paid for, what we can legitimately get paid for, and what we can't get paid for, and that becomes our work. It defines our work. And it's not surprising in whatever system you have in a world of productivity pressure that whether it's fee-for-service or AFP or whatever, that to keep things moving, we have to have 10-minute appointments. And so every time that a patient takes 5 minutes longer, somebody else has to take 5 minutes less, or you keep everybody waiting for 3 hours, and that's the reason why that happens. I think there's another thing that's going on here with standardization and guidelines. Who needs to take a history when a scan will do? And I think there's a lot of that towards the end of the 10 minutes or 12 minutes or 8 minutes. What am I going to do to get the patient out of here? And one of the things that we adopt as a strategy without even thinking about it is testing. We do a lot of testing, over-diagnosis, and often we find the right thing, sometimes out of luck, sometimes we find things we shouldn't find, because if we begin to work up an incidentaloma, we're going to end up taking a patient down a path towards more harm than good. We can talk about how empathetic we are to patients, but I ask you, how empathetic are we to each other? This is, I wrote a book, The Secret Language of Doctors, and I went to some places where they refer to M&M, morbidity and mortality rounds, as jousting. Now, I'm sure it doesn't happen here. I'm sure that M&M rounds here are affirmative, they're positive. People volunteer to describe their worst cases because they know that they're going to be treated really well, unlike other provinces, other hospitals in other provinces where that isn't the case. Anyway, how can we be empathetic to our patients if we're not empathetic to each other? I ask you. And I've seen too many people who have that split where they're really nice to patients and really nasty to each other. Whether it's competitiveness or whether it is one-upmanship or pushing people's insecure buttons, making sure in every verbal conversation, every interaction between referring physician and consultant, that everybody knows who's top dog in the power differential. Why do we do that? Well, as one anesthesiologist said to me in my book, when your last exam was 30 years ago, and everybody knows who won the gold medal and who won the silver medal, how do you compete? Well, you either compete with prestige or power or money. Take your pick. So my point is, we're not particularly empathetic to each other. What's the cost? The cost of this lack of empathy to our patients is errors and bad outcomes. Because if you're not empathetic, there's a good chance you're going to leave the hospital because you're dead tired. And even though that still small voice is saying, I got to go back and check that lab result, you won't, because you're exhausted. You'll be emotionally exhausted. You'll suffer from compassion fatigue, which is the phenomenon of no longer being able to respond in the moment emotionally to a patient's distress for a whole bunch of reasons, one of which is that maybe you've heard this story 300 times, and maybe you haven't vented your own feelings about it. Moral distress. You end up practicing in a way that goes against everything, every fiber of your being, everything in your heart that says this is just the wrong way, but you have to keep doing it because the system demands it. And so you suffer from burnout. And to our patients, errors and bad outcomes. Good news. Newborns are hardwired to display empathy. Newborns cry when other newborns cry. Newborns display signs of distress when their parents are crying and not anybody else's parents. So they're hardwired, like I'm not them. Like we don't come from them. We are hardwired to be empathetic. I'll give you another tip. Empathy is very good for healthcare practitioners' health. Higgins did a study. Medical students trained in empathic responses showed more compassion in patient interactions, and their stress levels during these encounters decreased. So it's good for us. I miss this guy, Rob Buckman. Dr. Rob Buckman, who was a comedy writer and a physician, a brilliant oncologist, who moved to Canada and then made a name for himself writing books and giving speeches everywhere about how to break bad news and how to be empathetic. And he taught me how to be empathetic in the most horrible situation of all in the emergency department, which is when you're telling a loved one the shocking news that will change their life forever, that their loved one has died. And he taught me. And he taught me by simply reminding me that it doesn't matter the words you use. What you do is give the person you're giving the news to the space to feel what they feel, to say what they say, and acknowledge what they're feeling. And I had a situation in which I was with a woman who was grieving the sudden, tragic, unexpected death of her husband, who she had spoken to 2 hours before. He said he had a little indigestion, and it turned out that it was a heart attack. It was an ACS. And he was brought to our emergency department in cardiac arrest, and we worked on him for a long time, and we weren't able to revive him. And eventually the code was called. It wasn't, I wasn't the lead physician. It was my colleague. He did the right thing because it was too late. And then about 2 hours later, his wife was brought in, accompanied by 2 burly police officers. And you know, there's a code in emergency medicine and probably in other parts of the hospital that you pronounce, you tell the family. And I remember following the 2 police officers accompanying the woman to the cubicle in the resuscitation room where his body was. And then I asked my colleague, do you want me to be there with you? And he said, no, I can handle it. Code, I do it. And I remember the sliding doors closing and the screams starting. And I went to do some other business, and when I came back, one of the nurses said, Brian, can you go in there? We can't reach the wife. She's just in another space. And when I found her, she was shaking her husband's lifeless body, trying to wake him up. And I remember, I tried, the acknowledging comments, hard to believe, difficult to believe, must be horrible. And I wasn't even reaching her. And I wondered, how was I going to be able to do that? And then suddenly I could feel Rob Buckman on my shoulder urging me to just acknowledge what she was doing. Well, what was she doing? She was trying to wake her husband. And so instead of getting past that because it just seems so weird to all of us and we need to move on and she wants this moment to last forever because the next moment is just far too terrible for her to comprehend. And so I started to say haltingly, you keep shaking your husband to try to wake him up. And it felt right. You keep shaking him to try to wake him up, but you can't, I said, because he's dead. And the spell broke. She said, it was the most innocuous thing. She said, I've got to go to the bathroom. And she did. And I've been in these rooms where people won't even sit down. They're just pacing around the room as you're telling them this news because they feel as if they sit down, it's game over. This person really is dead. And you need to be able to understand that it's not about us. Well, why do we find it so difficult to do that? Well, it is hard. It's heart-wrenching. It's difficult. But there's another reason why. We keep involving ourselves in what the patient and their family is going through. We're defensive. We're afraid we're going to be accused of not doing our best or making mistakes. And we let that defensiveness get in the way when it's all about the patient and their family at that moment in time. And if you know that, if you understand that, maybe you'll be a little less defensive the next time you're in a difficult encounter. We're also here to talk about this. Patient engagement is something that Kingston General Hospital decided they had to do. And I'll let you hear Leslie Thompson in just a moment, the brilliant CEO of that hospital, talk about why. What they do there could be a model for what you're going to do here. They have patient and family advisors, former patients, family members of former patients, people with stories to tell, patient experience advisors, people who can say, I know what it's like because I've been through it. And they serve on every major committee in the hospital, no exceptions. They even sit in on interviews for new hires, asking questions because they're part of the hiring committee. If a new building is going to be built, they're brought in. If they're going to change the menu for patients or in the cafeteria, they're brought in. They also are beginning to deal with having conferences to debrief after major incidents. But as you can see, there's plenty of mundane stuff to keep patient experience advisors busy for a long time. Some of the things that they have accomplished, well, their credo. You've heard this before, nothing about us without us. Why? Because if I'm doing rounds with the family, if I do it in a cubicle or in the bunker or in a back room, there's a good chance that I'm going to miss some important piece of information, whereas if I do it in front of the patient, or if nurses hand over to one another in front of the patient instead of in a back room, there's a good chance that there'll be a family member there who can correct some vitally incorrect piece of information. That's something that was brought about through patient experience advisors and through patient engagements. This is a small thing, but small things make a big difference. Daryl Bell is their point man, chaplain, but also point person on patient engagement at Kingston General Hospital. The patient experience advisors said, we can't read your name tags, change them, and they did. Big focus on the first name, photograph, and big letters, what they do. Because very often, patients will say, and family members will say, people are going in and out, and I have no idea who's who. A lot of hospitals are experimenting with high-tech gizmos to monitor how often people like me wash our hands. They went low-tech. They simply said, post a sign at the beginning, at the entrance to each ward, saying what the hand-washing rate is. Their hand-washing rates were 30-40%. They went up immediately to 90-95% and have stayed there ever since. Here's another example of patient-centered initiatives that isn't being done at Kingston General, but could be done there, could be done anywhere. I know it's being done here in Alberta, posting ER wait times. And in the culture of medicine, I have had lots of smart emergency physicians who've said to me, Brian, you're an idiot for talking about this. Because it's garbage in, garbage out, and you're only going to get somebody who's having chest pain from a heart attack to go across town to the hospital with the quickest wait time when they should be going to the nearest hospital, as if you can't educate people to do that. Yeah, they have legitimate beefs about this kind of initiative, but my point is, they're missing the point, and that is fundamentally posting an ER wait time, or any wait time for that matter, is all about saying, I care about you. I care how long you're waiting. I'm going to update you as much as I can in a regular way and not make it seem as if I'm doing you a big favor in the process. I said I was going to let you hear Leslie Thompson. And I want you to hear a couple of minutes of her because you need to know why they did it. Where were they coming from that made them want to make this journey that you're about to embark on now? Let's hear that clip. Oh no, got to go back. There you go. There it is. You got it.
I can think of at least 3 examples where the experience that the people had with our hospital was so difficult. It was so horrible that it took a long time for them to believe that we were serious about wanting their input, and some of those individuals have made the most profound differences. Our infection rates were terrible, 34%. It's appalling. The way it was. Yeah. We are now consistently like 97% across all categories of staff, and we've sustained that for the past 2 years. One of the reasons why that shift happened was working with our patient experience advisors to think about the why, bring it really visible. So you walk onto every unit, there's a big sign that posts the hand washing stats. That was their idea. Equipping patients with being able to ask with more comfort, please wash your hands. They came up with ideas about how to move this forward that we just wouldn't have done on our own. So we made a declaration that any decision in our hospital where there would be a meaningful or material impact on the experience of patients, a patient would be at the table. I remember standing up there and going, I have no idea how we're going to do this, but I know it's important. So let's figure it out. And now we've got people at tables they never were at before. They're part of the decision-making and the problem-solving before we come up with a brilliant idea. It's very important that it's kept real. There should be a tension that exists to keep it all authentic. If the patients ever start to be the real cheerleaders for the hospital and take on that role as opposed to the sober second thought, the lift. It's like being an executive in any committee. If you start to hear everybody agreeing with you, you know you don't have the right people at the table or you're missing something. They need to be free. And if a patient feels like they're being held up as a poster child for look at the hospital, how great they are, or as a, something that the CEO can tick off their list of saying, look at me, I'm great, it'll be over. I remember members of our board, our staff, and the community listening to some of the things that were being said. It was really tough. And it's on video. It was being essentially broadcast out. And
they said difficult things about the hospital.
Oh my God.
Yeah.
They talked about where we let them down. They talked about what it felt like to be let down. And where we didn't meet their expectations, where it hurt them and their family physically and emotionally. Remember someone saying, well, this isn't what you do as a hospital. You should be, and even the foundation, why are you doing this? People won't give you money, or this is not good for the reputation. I said, this is everything about our reputation.
Greetings from Leslie Thompson through the magic of Twitter. Alberta's effort to jumpstart patient engagement, terrific. Patients as partners equals the only way. So she's right here with you today in spirit. Couple of other things before I close. You can't have patient engagement without transparency. That's the Trivago guy who everybody seems to like to lampoon on YouTube and on the internet. But my point is comparison shopping for a trip, a car, insurance policy is easy. Comparison shopping for doctors and hospitals is almost impossible. And I know Kai is starting that conversation, but we are nowhere near where they are in the UK, where they had the mid-staff scandal, where as many as 1,200 people died as a result of widespread negligence at Stafford Hospital, run by the NHS. It led to a public inquiry. It led to an extraordinary apology by the Prime Minister, David Cameron, the day the report was handed to the British government. It also led to the creation of something called a whistleblower in chief. This is a government inspector called the whistleblower in chief who systematically investigates hospitals proactively. And they are changing that culture that discourages medical whistleblowers, but it's easier said than done. Now they're moving on to transparency. So in 2014, UK surgeons must post their operative mortality rates or face sanctions. Now, the surgeons in the room are saying, Brian, I'm going to have a higher complication rate if I take the toughest patients. And that's true. And that has to be built into the metrics. But it doesn't mean that we shouldn't attempt to be transparent. And Kai is starting that conversation. We got a long way to go on that. The old way was that. The new way is doctor shut up and listen. And there are programs, healthcare professional communication training program in Harrisburg, Pennsylvania. Standardized patient encounters, physician coach observes actual encounters. Not for students, this is for people in practice like me. The result is a 40 percentile point improvement in patient satisfaction scores. They leapfrogged over 40% of the hospitals in America. Pretty amazing. Slow down. This is a wonderful book by Victoria Sweet, God's Hotel. It's called Slow Medicine. It just means slow the heck down. I don't need to say much more about it. Remember that. And I want to nod to this because I had a little bit of a conversation about narrative medicine, the power of story. Narrative medicine is medicine that combines clinical competence with narrative competence, the ability to bond to patients by understanding the complex narrative situations among doctors, patients, and colleagues, and their patients, and how that's what makes every patient unique. And we have Rita Sharon to thank, an internist at Columbia in New York City, who is the doyen, the English PhD and internist, who was the first person to bring narrative medicine onto the curriculum at many, many medical schools, including here, the University of Toronto, Dalhousie, etc. I guess the dental students weren't part of that. I'm out of time. Last photo. I promised that I would leave most of the emotional punch to what will follow, what has preceded and what will follow, and I'm going to obey that. It's a shame that we have to become sick as patients to understand what it's like to be patients. I can also say by corollary, it's a shame that we have to experience the healthcare system from the other side of the gurney by being the loved one of parents who were ill and certainly lived up to that old truism that they spend more money on the last 2 years of your life than they do in all the years in between. But I would not be up here talking to you if I couldn't honor the memory of my parents who both passed away in the last 16 months, who were, as they say, avid consumers of healthcare services. They had some experiences that were awful. They had some experiences that were wonderful, in particular the last hours of my mother's life this past September 30th. It's a shame that we have to experience it from that side to know what it's like. It would be nice if there was another way. But I can say this, if you do have an experience, for God's sakes, remember it, use it, because it will help make you better at what you do, and no one will lose. Thank you.
To remind us that there are good experiences in healthcare. And before we get to our next duo of speakers, we're going to hear John's digital story. John had a positive story of the healthcare system, and here it is.
On a cold, dark November afternoon, the doctor came into the room and asked to speak with me. My wife Dawn was in a coma and had been on Unit 36 at Foothills Medical Center for 2 weeks. We were told when she was admitted through emergency that Unit 36 was a special unit where very sick people were treated. I had no idea what my family would experience over the next while. During the next hour or so, the doctor reviewed my wife's condition and the fact that she was not going to make it. We talked about palliative treatment, and I asked if she should be transferred to a hospice. The doctor suggested that she should remain on Unit 36 and that they would ensure that she was comfortable. I asked if she would also come back and take some time to explain my wife's condition to my daughters after I'd had a chance to talk with them myself. Dr. Hawkins, Laura, Emily, and I went into a quiet meeting room and reviewed what had happened over the last couple of weeks and why further treatment was not going to change the outcome. Dr. Hawkins spent the time with my family ensuring that our daughters understood what was happening and answered all of their questions. When we went back to Dawn's room, a nurse came in and very kindly and carefully spoke with my daughters. She said that she wanted to make her comfortable and guaranteed she would be well taken care of. The nurse asked them to go and get a favorite nightgown of my wife's and some of her perfume. When they returned, the nurse asked us to give her some time. When we returned to Dawn's room, she'd been disconnected from all the pumps and monitors. The nurse had bathed her and got her into a nice nightgown, brushed her hair, and dabbed on some perfume. She looked more like herself again. The end came within a couple of days. As promised, Dawn did not suffer. After she died, we were told to take as much time as we needed. I left the room to make some calls, and when I returned, the nurses had placed a sign on the door stating that we were grieving and to not enter. I will always be grateful to the staff of Unit 36 for their kindness and compassion.
So sometimes we get it right. Our next duo of speakers are Dave Price and Ward Flemons. Dave will be speaking for the bulk of the time, but I'll introduce him first. Dave, like all too many, has gotten heavily involved in creating a patient-centered system because of a family tragedy. Dave was born and raised in Alberta and is a businessman. He's one of the founders of the Sunterra group of companies. He's given a lot of social capital to the system, particularly on the boards of college and as a chairman of the Golden Hills School Board. The thing about Dave, he's the father of Greg Price, who's someone who was terribly missed by Dave and his family and his friends and his community, and who died prematurely because of multiple failures in Alberta's medical treatment system. And the thing about Dave, having gone through this, and Dave's background is he thinks like a system fixer as well as someone who is responding to an adverse event. So people like Dave are extraordinarily valuable to the kind of system we are trying to build. Before Dave talks about Greg's story, we're going to hear from Dr. Ward Flemons, who is a colleague and friend. He's a respirologist and a professor of medicine in the Cummings School of Medicine, and he's the Quality and Safety Education Lead for the O'Brien Institute's Ward of the 21st Century, which is not named after Ward, actually. And he's been a champion of quality education and leadership and safety culture for decades. And Ward is going to begin by taking you through the technical medical journey to show you exactly what happened to Greg, and then Dave is going to draw the larger picture for you. So over to you.
Thanks, Stephen. That's the first time I've heard it wasn't named after me, but I'll try to work through that. And thank you to everybody for coming this afternoon. When Dave and I were talking about this, and I've had the privilege of speaking with Dave on many occasions and getting to know the Price family, and I'd just like to acknowledge that Dave's family is here. We thought that as we wanted to present Greg's story, it would be useful to put into context the medical journey that Greg had before Dave tells you a little bit about who Greg actually was. So I'm just going to cover that in a very brief time here. So very briefly, in April of 2001, Greg was a pilot. He needed a pilot's medical examination, and he went to a local family physician for that, where an abnormality was noted around his right testicle, and it was recorded as a thickening of his epididymis. There was no distinct follow-up plan for that because the significance of it was not clear. In December 2001, many months later, he started noticing some back discomfort. As you'll learn, Greg was an athlete. He put this down to some back strain related to his athletic endeavors. But in January 2012, he went to see another doctor for a different problem, which was just a simple rash. And he went to a walk-in clinic in a different town, saw a doctor. Treatment didn't exactly work, so he decided to go back and see the doctor that had done his pilot's physical in February. And at that time, the doctor decided he would re-examine that epididymis to see if it had gotten better. It had not, and it decided that he would refer Greg to a surgeon for a second opinion, expecting that would take a couple of weeks to do. It turned out that Greg didn't hear from that office for 94 days. Meanwhile, Greg's back pain started becoming worse, and Greg decided to go and consult with the doctor he'd originally seen about his rash at the walk-in clinic. That doctor decided that he would order some ultrasound tests and some x-rays. It took Greg approximately 7 days to get the ultrasound done, and when he got the ultrasound done, it showed that he had an abdominal mass that was pressing on his inferior vena cava. The radiologist came out and spoke to Greg about that and said he needed an urgent CT scan. She also phoned the family or the walk-in clinic doctor to tell him the same thing. And 7 days later, Greg was able to finally get back into that walk-in clinic to have the discussion about getting the CT scan ordered. Although it was deemed to be urgent, because Greg had suspected cancer, not known cancer, it was deemed a priority 2 scan, which meant it needed to be done within 30 days according to protocol, and Greg had it done 19 days later. While Greg was waiting for the scan, the walk-in clinic doctor left the walk-in clinic unknown to Greg, and there was no doctor to follow up the results with. A week after his CT scan, Greg phoned the walk-in clinic, learned that the walk-in clinic doctor was no longer there, and was invited to come in and see another doctor he'd never met before, which he did. and they reviewed the CT scan results, which confirmed that he had a large abdominal mass, and in a young man like Greg, suspected that it could be a testicular cancer source and recommended an ultrasound of his scrotum, which happened the next day. Greg now needed to go see a urologist and was referred by that second walk-in clinic doctor to the urologist, and Greg waited. And a week after, having expected to hear from that office many days before, Greg phoned to find out why he wasn't getting any care and learned that the urologist was out of town, had been out of town, and would be out of town for at least another 2 weeks. Greg phoned back to the walk-in clinic, got referred to another urologist, and was seen in relatively short order. 2 days later, Greg was scheduled and went in for an orchidectomy to remove the cancerous testicle. The first post-operative day, Greg had the experience of increased swelling and had now been on narcotic medications for a week or two because of the pain, and things were getting worse and he wasn't sure what to do about that. The second post-operative day, Greg decided he needed to reach the urologist to get some advice because things were getting better, or getting worse, not better, and Greg, although it was a normal business day, could not reach the urologist's office nor anybody else that was covering for him. With no other options, he went to the emergency department. He was taken there by his father, Dave. They went to the emergency department after speaking to healthcare professionals who were friends, family members, and they were advised to talk to the doctors about the possibility of blood clots. When Greg got to the emergency department, after waiting, he was taken into the back room for an examination. Dave was not allowed to go with him until it was okayed by somebody in the back. Greg left the emergency department after they confirmed that he needed a cancer clinic appointment. It was being worked on. He would hear from them very shortly. He went home to convalesce at his parents' home, and the following morning he collapsed when he got up out of bed. EMS was phoned. They came. They tried to resuscitate him. They took him to the local emergency department. He unfortunately was unable to be resuscitated. At autopsy, Greg was found to have massive pulmonary embolism and massive clots distal to his obstruction from his IVC pressing tumor. That was Greg's medical journey and experience with the medical system. I'm going to turn things over to Dave so you can learn a little bit more about Greg and also Dave and his family's experience with trying to help healthcare change.
Well, thanks, Dr. Flemons, and I'd also echo earlier thanks for everyone taking the time to come today and to learn. It's certainly a new opportunity to be able to try and engage and have the public better understand what's going on with things like the assumptions that we make. I'm not as polished as some of the earlier speakers, so if I'm looking around bewildered, that's because I am. There's no monitor here, though. Oh, up there. Okay. So this is the time continuum that kind of shows what Dr. Flemons actually talked about, and you can see from it, and certainly you can refer to it later in the HQCA report on continuity of care. I would like to publicly acknowledge and thank Dr. Flemons and the team at the HQCA, including the board, for the courage that they took in actually taking on this investigation and being willing to go through it and spend time with us, which we certainly appreciated, in being able to learn more and to be able to communicate what our experience was after Greg's passing. A little bit about who Greg himself was. There we go. That was supposed to be the one that you were seeing. Now you can look at this one. So he was born on April 5th, 1981 here in Calgary, actually at this hospital, and raised on our family farm, mixed one about an hour outside of the city here, a big metropolis of Acme with a whole 600 people in it. He had 2 brothers and 2 sisters. Some of those are here along with my wife today. And he was always a happy youngster, always keen and willing to try anything. And then as he grew up and graduated, he spent time enjoying sports. He loved being fit. He spent quite a bit of time doing that. engaged in the fundraising runs and bike rides that would do that for different causes. He played on a number of different teams, both in and outside of school, community teams. Loved baseball in particular. Also played on high school basketball, competed at the provincial level, and also gave back. He came back and helped coach both school and community teams. Once he graduated from high school, he went to the University of Alberta, graduated from there as a mechanical engineer, and he went to work in different areas. He spent time locally working for a fabrication company that builds machinery both for the oil patch and for agriculture. From there, he decided he wanted to be able to be involved in something bigger, and he actually worked for a Schlumberger, spent time in different countries around the world, and really ended up missing his family and his friends at home and the sense of community there. He came back, became employed with a smaller gas company in Calgary, and used to live and commute from our home community. He always enjoyed helping out friends, and he loved, as you can see in the picture on the right, he loved the next generation, his nephew, and indeed, as Ward mentioned, during the process he earned his pilot's license and liked the opportunity to be able to take friends and family with him on trips that he could go on. One of the things that we learned after Greg's death was that he kept what we call little books of everything, and in those he had a number of quotes that he used to guide him forward. And here are three of the quotes that we took out of those books that kind of demonstrate the kind of person that he tried to be. And I'll just read those quickly. The men who try to do something and fail are infinitely better than those who try to do nothing and succeed. My best friend is the one that brings out the best in me. A century from now, it will not matter what kind of car I drive, what kind of house I lived in, or how much money I had in the bank. But 100 years from now, the world may be a better place because I was important in the life of a child. Greg was tenacious in the pursuit of his goals, whether it was fitness or in the business that he's created or the work that he was doing for others. He always looked for the best in people. He was selfless, he was respectful, and those things made him very vulnerable to the current medical or health system. As a family, we only knew about the seriousness of Greg's condition when he chose to bring us into the picture on that. He was worried about us worrying about him. He told us after a fair amount of pressure from his mom on a Sunday night about what he had come to believe his situation was. We attended the examination by the surgeon on Monday, the next morning. After that, he wanted to write an email and send that out to his friends and family just to bring them into the picture. Wednesday, he was operated on. Thursday, Dr. Flemons talked about the swelling and that concerning him. Friday, we organized for the trip to emergency. Saturday morning, he died in our home. Go ahead and play the video now, please. This is of his email.
Okay, one of the things that Greg did after sort of getting to the point where he had realized exactly what was going to happen and had confirmation from the doctors involved was to inform his family and his friends. And he did that by writing an email that he sent on Tuesday morning prior to going into surgery on Wednesday. And here's what he had to say in that email. I wish I had better news to be contacting everyone with this morning, but wanted to give everyone an update at once. Yesterday I was diagnosed with testicular cancer, or at least a 99% probability of. I've been experiencing some symptoms for a number of months, mainly lower back and abdominal pain, and over the last few weeks the diagnosis has led to testicular cancer that was confirmed yesterday. The abdominal and back pain is a result of a relatively large mass present in the back of my abdomen. I'm scheduled in for primary surgery to remove one testicle at Rockyview General on Wednesday. It's planned for just day surgery with the possibility of one overnight. Tissue samples will be taken and sent to the lab to determine if the specific type of cancer cells. These pathology results will take about a week. This will give final confirmation of the diagnosis and guide the next treatment steps. Most likely treatment will be several rounds of chemotherapy and/or the possibility of further surgery. I'm sure that this is a little overwhelming and a shock to everyone, but I chose not to talk about it much until I knew for sure. Testicular cancer is one of the most treatable cancers with an extremely high cure rate. I am confident that I can come out of this in several months, stronger than ever. As a final note, I want all of you to know that while I haven't been forthcoming about my challenges and diagnosis up to this point, don't think that each of you hasn't been supporting me. I'm blessed to have the most incredible family and friends, and it is through this group of shared experiences, memories, and futures that I gather considerable strength. Christmas dinners, random road trips, bad jokes, late night movies, unexpected overnighters, acting like kids and playing with kids all make it easy to get up in the morning and look at this challenge as merely a bump in the road to be overcome and no more. Each of you gives me more strength than I will ever be able to describe, and for that I have all of you to thank. All the best and see you soon. Craig.
So, my talk is going to focus a little bit differently now, and rather than necessarily talking to the medical community, I also want to be talking to the public. And so one of the questions are, why are we doing this? Well, it's what Greg would have done. I made the mistake of looking over at my family. Greg cared. He really wanted to make a difference in the world. At his funeral, a number of people got up and related their own experiences. And they talked about his genuine interest in them, how he connected, how he made them feel special. From our perspective, it's important to share Greg's journey, its lessons, and its warnings, and that's the work that my daughters have done in creating the website called Health Arrows. There, the full detail of our view of Greg's story is written. It's available there for anybody to use. The idea is to try and have people better prepared for what might come of them going through the system, and to be prepared for that and to not end up being caught in the same gaps that Greg tried to deal with himself. Our overall goal, of course, is to help try and transform the health system. So when we decided to start on this journey, and it was after we were confident that we would be more than just a grieving family, and that was the result of course, the work that the HQCA did and the fact-based development and recommendations of the report that they did. And early on, our decisions were that we didn't want to take any legal action. We wanted to make sure that the doors were wide open, that we'd be able to work with people rather than bumping against the barriers that would have those legal doors slammed down. And we also didn't file a complaint with the College of Physicians and Surgeons for the same reason. We weren't interested in individuals. We were interested in trying to be positive and affect system-wide change, a culture change that needed to happen. We wanted to be proactive, to provide positive reinforcement, and to publicly celebrate good work and improvements. There's good work being done. There's great people working. that's what we wanted to be able to highlight and cause improvement and to sort of continue and generate momentum for change, positive change. Our early hope, as I've said, is open engagement, and we were looking for early progress in 3 particular areas. After-hours care. That's one that's been surprising to us, that the tolerance level has been at a very low compliance level. And all we were looking and expecting to happen is if we shone some light on this, the standards of the college would actually kick in and be met. And that's not really changed in the 2.5 years since Greg's death, 2 3/4. Patient support access. Often you'll talk to people that say, well, there's no policy that says that you can't accompany your sibling or your child or your parent. As Dr. Fleming said, I was prevented physically from accompanying Greg to his last examination. And that kind of barrier still exists today. And in the digital electronic world, as somebody from the outside that makes assumptions about the healthcare world that we're spending billions of dollars on, keeping pace with the rest of the economy and the other sectors that are working, shattered by what we learned about the dysfunctional, fractional, fax-based, in a lot of cases, record system. And so there's clearly needs to be something done with that. It's decades behind what we're used to in the rest of the world. And our longer term hope, again, is to help dramatically change the culture, the actual culture of the system. We've had people before me talk a lot more eloquently about what that actually looks like and means and perhaps why, but it needs to change. So, what have we been doing, or what are we doing? Well, we cooperated fully with the HQCA, helped them and helped us with the understanding on Greg's journey. It was very good interaction on the area that they were able to investigate. The Alberta Health System part, we interacted with people from AHS, we learned some things there, but the reports are internal, confidential, not for our eyes or the public eyes. We've accepted invitations to speak provincially and nationally. People always have their own stories, and very often, probably like this audience, there's an awful lot of the audience are healthcare providers of one sort or another, and it's amazing how many times people will come up and they will start with, I was lucky. That's a terrible perspective to have on a system. Why do you need to be lucky? And it's always a result of somebody intervening or some point that people were able to actually change the course of what was not a healthy direction for the patient, the loved one, or the friend that was involved. We've accepted invitation to work with others, and the family members are volunteering on other committees. We're doing what we can to try and have some good come out of this terrible tragedy. And of course, we've listened as patients and families have come to us to sort of share their stories. Heart-wrenching ones, just like you've heard speak about earlier, and you've had a couple digital stories about it. And the sad part is that they're no longer surprising. It's way too common. It's more than ever the reason for dramatic change. I have a nervous finger, but it obviously isn't being able to get through there. Normally it'd be a couple of pictures at a time. So what's been our experience? Well, we started out asking not to be handled. We just wanted to know the truth. Wanted to know what really did happen, where the gaps were, recognize we were coming from way behind the curve on what the information was. We asked a lot of basic questions, things that would help us put things in perspective. Many questions, few answers. Oftentimes it was explained to us, well, this kind of occurrence is normal. this kind of activity is normal, this time frame is normal, as if that's should therefore mean it's acceptable. It's not the right measure. Normal isn't good enough in any other sector. You have to be working to get better. There's lots of barriers. We've had explained to us how complicated and how complex, how big it is. And a new expression for us, we can't boil the ocean. What a terrible perspective, really, to say that that's the task. A few other experiences. We waited 7 months for the medical examiner's report. It contained a pretty significant error as far as we were concerned. It didn't document the fact that Greg had post-surgery swelling prior to and pre-surgery swelling prior to that surgery and running up to the emergency visit. We were surprised that they weren't prepared to correct it. In fact, I was asked if I could provide written documentation that that was a fact. Medical examiner's office is in the Department of Justice. It's a third party. It has all kinds of authority, more than anybody else. And yet that's what I was asked to do in order to get that error corrected. And even when it was provided, it was not corrected. We asked for a fatality review board investigation. That was denied. We got a one-liner basically saying, nope, not going to do it. We exchanged opinion letters and conversations with Dr. Thiemann and the CPSA, College of Physicians and Surgeons of Alberta, regarding what Dr. Horn had asked him or them about the recommendations in the HQCA report. That information is posted on Health Arrows if you want more detail of it. Certainly appreciated the ability and the willingness to talk to Dr. Thiemann and have those exchanges, but there's way more needs to be done than talk. There needs to be some serious action taken on everything from those after-hours care standards and on a number of other fronts that the CPSA has some influence on that come with the recommendations of the report. We had a positive experience with the AMA. We presented at the Representative Forum just about a year ago, and outcomes of that were resolutions being passed about directions or things that need to be done. They can't do it on their own, of course, and we would have hoped, and perhaps after today, we'd like to see quicker action, more progress made. So what have we really learned? Well, this is a patient's family's view of what the health system is. It's managed top down. It's all about command and control. It's a patient treatment system, not a patient care system. That culture pre-existed the former minister, but it certainly was hardened by the tactics and the firings that happened during that tenure. During our meeting with people and seeing good work done in different parts of the province, it's pretty clear to everyone they're not safe. If you can fire an independent board and get away with doing that and move on from there without any real ramifications, then nobody in this system or in the province is safe from that unless there's change, clearly. As I say on the slide, there's many good people. No, still, I had my finger going when I didn't know it. So the last point there, many good people and pockets of great care. I don't want to have the overarching theme here that everything's in the dumper. It's not. We've got great people doing great work. The problem is at the culture and the broad system level. The ones that are doing that work are doing it by their own admission, some risk to their own future, their own careers, and they also say at risk to their care for their patients. That's one of the frustrations that we had. One of the goals of the Health Arrows website was to shine a light on those people. Every time we talk about that, no, don't do that. No, and we don't want to stand out. That's not a good thing. We will lose if we do that. What a terrible way to be looking at the world. Now we'll get to this one. So what do I mean about patient treatment versus patient care? Well, you heard a little bit earlier from the speakers before. Patient treatment's vertical. It's individual decisions, individual incremental actions, individual steps, individual payment, vertical. The other part of it is when it's done that way and accounted for that way, it usually means you're unable to measure and track what happens in the bigger picture. So you end up with just a bunch of pieces, not the puzzle. How can you possibly move a system forward and improve if all you're doing is looking at pieces, not the puzzle? You don't have the picture. Patient care, on the other hand, is a team effort. It's built on each member's strengths and how they can contribute to the end goal of the whole care. It is available 24/7. No patient is ever discharged from care. No patient is ever discharged from care. The team is in place 24/7 and it goes around. The other part that is important is that it is collaborative. It's engaging the patient in the decision-making partnership. It's a partnership. The patient has things to offer. They certainly have things they can deliver, and they can be part of the process of ensuring all the steps occur along the continuum. Greg knew his condition better than we did, and we believe better than the surgeon did. He asked questions around an alternative approach to his treatment. Major surgery, remove the mass, get the pressure off his IVC, and then move into the treatment on the testicular cancer after that. The response was that, we know what we're doing. We've done thousands of these. You're not going to die. That kind of dismissal. That's what we had. Another thing that, from our perspective, it was noted a little bit in my introduction. Our experience is in the food industry. We've had to work in an environment, and we are willing to work in that environment where there's a system in place to ensure that human failings and mechanical or process failings are covered. To put men on the moon and to put men into space, NASA developed a system in the 1960s, older than most of you in this room, that was called HACCP, Hazard Analysis and Critical Control Points. It was a way of looking at all of the what-ifs that could happen in the process to their outcome. In the food industry, we have to do that before we can open the doors and do business. If the lowest inspector in a plant detects or believes that there's a risk that's not properly accounted for, business stops. This audience here should remember what happened in Brooks a couple of years ago. 2,500 people or so out of work for a number of weeks. Finally, the Canadian Minister of Agriculture and Food needing to sign off before they could go back to work, a new ownership group, and then they could go forward with a new set of standards and be able to proceed from there. How many people actually died in that event? None. 14 were ill. The health treatment system that we have just keeps doing what it's doing. There's no interruption. There might be an investigation, but the business just carries on. What I'd like you to do now is think about from your own perspective, particularly those of you that are from the public. What are some common experiences? And I'd like you to stop and think about them. Is that a treatment regime, or is that about patient care? Brian did a great job of some of the things there, so I won't spend a whole lot of time on that. But he did the one on clinic receptionists. My question is, why are the gruff ones always hired? Why are they the ones that actually are at the front line? What other business could stand that? Really? What about the sign? See the picture there? You're welcome. Note, 1 issue per appointment. If you need another one, make another appointment. Is that treatment or is that care? The doc that tells us, as we were told, or as Greg was told, don't call us, we'll call you. The flip side, of course, is we've had those too. Sure, here's the number, call us anytime, or call the pager and they'll get me. Anytime at all. Pretty different treatment versus care. What I'd like you to do is stop and think about those experiences of your own. You'll have ones that we don't have. So, from our perspective, what's needed? Well, we start with new priorities and new direction for the new political leadership. We've got an opportunity now, as the public and the system, to be engaged and be part of establishing new priorities and directions. Since Greg's death, 3 premiers and 2 health ministers. It's too early to see change in the patient treatment system now. But what we need is strong public engagement to establish and set priorities required on all levels. We all have the responsibility. Individuals, families, providers, indeed the media. Media has a role in this too. Stop and think, ask the questions. Does it sound like we're making progress? Or is it just justifying what's happening or reinforcing the treatment regime? Universities, college institutes certainly appreciate the forward-looking and initiative that's taken here at the U of C and what's happening here today. Training and attitude start there. Start as the students go through the system. Whatever's happened in the past, there's a critical failure there because we've lost, as Brian said, we've lost some of that, the heart part. It's up here, it's not here. You got to remember those are connected and need to be balanced. So I'd encourage everyone to stop and assess decisions. Question whether it's moving things towards care, and obviously oppose and let people know you oppose those that reinforce disjointed and dangerous treatment system. I got 2 instead of 1. There we go. What's it feel like as a patient or a patient's family? Well, it feels like many people that work in the system either don't care or they're not allowed to provide real care. Either way, it's just treatment, right? The next part of that is, Brian talked about having a smile, a happy face on. Well, it's not healthy for either the patient or the caregiver to be in a space that's like that. You need to feel good about what's going on. You need to be partnering in that care and have a bond with the patient so that you both can move forward and feel good about that and celebrate it. It can be tough stuff, but you need to work on it together. We need to work on it together. Just a few examples that we've had over the last, it'd be 6-8 months. Let you categorize it. My granddaughter was not very well, getting lethargic, run a fever, not normal at all. had a trip to a clinic actually and had an assessment and, you know, go home and be medicated, be okay, just keep an eye on it. She's 3. Decided that that wasn't actually progressing. So after all hours, call to HealthLink. Go through the checklist. Oh no, it's okay. Just keep monitoring, it's okay. Time goes on. Finally, her mother said, nope, let's go. We're going to go to emergency even though we're not supposed to need to. She was admitted and hospitalized for 3 days. Both of our daughters have had variable and disconcerting experiences, both on communication, on continuity, and certainly the care treatment angle. And on the flip side, our youngest son had prompt and outstanding care. Very efficient, very focused, very care-driven, and had quickly dealt with his fears and concerns, and he was happy to move on from there. So, take-home messages. Whenever we feel we face a challenge, Greg's grandfather told us, you've got 2 choices. You can either be part of the solution or you're part of the problem. Doing nothing is part of the problem. So, my ask, let's all be part of the solution. Every Albertan needs or will need care that is safe, continuous, collaborative, and patient-centered or partnered with the patient. That care culture does not currently exist across the system today. We all have to change that. Thank you.
Well, thank you so much to Dave, and thanks to the Price family for using this tragedy as an occasion to inspire us to be better. And I might say also that you did, in about 20 minutes, you gave a pretty good half-year course on health policy analysis and health system assessment, which should inspire the academics in the room to be more efficient in their deliveries. So it is now break time. Yes. Oh, sorry. We have one more.
I should have gotten up after break. My apologies. So what we wanted to do just before break time, and I'll let Stephen tell you about the break, but we wanted to tell you, show one more digital story. This is Greg's daughter, or Dave's daughter, Terry, experience. And I'm going to just quickly put the clinical context in place so that the story has maximum impact. So Terry was, this was 4 weeks after Greg passed away, and Terry developed some abdominal pain. She went to her family doctor who told her, I can't get you the tests you need as quickly as you need them, so go to urgent care. At urgent care, they thought she either had an ovarian cyst or appendicitis, and they told her that you needed an ultrasound. But you can't get one tonight, so we'll book you for an ultrasound in a private DI clinic for tomorrow morning. Return her when it's completed. Goes to the private DI center and they tell her, you don't have an ovarian cyst, you have appendicitis. You don't need a CT scan, you need a surgeon. Don't go back to urgent care, go to the emergency department and get yourself a surgeon. So that's what Terry did. The surgeon, after some delay, got to see the surgeon. The surgeon said, you do need a CT scan. I won't operate on you if you don't have one. If you don't want the operation or the CT scan, here's an antibiotic and please go home. CT scan was done finally. CT scan said, you have appendicitis, therefore you need an operation. Oh, by the way, the CT scan also showed, incidentally, you have an abnormality of your bladder. You'll need to see a urologist as an outpatient. Operating room nurse post-operatively says, can't tell you if your appendix was perforated or not, even though you asked me. We have no bed for you, could you stay here for a while, for quite a while. Finally, in the surgical ward, doctor never seen before, comes in, says, you'll need antibiotics because your appendix was perforated. And the first question in Terry's mind was, who are you after all? And finally, you can expect a call from a doctor, a urologist. Here's the doctor's name. It turned out to be one of the urologists. Greg was referred to 3, as it turned out, one of the urologists that Greg was referred to. We can play the digital story now.
I don't know where to start. I lost my brother Greg on May 19th of 2012. The healthcare system failed him. A cancer that 95% of patients survive resulted in his death 3 days after surgery and a day after a trip to the emergency room. A few weeks later, I was walking with my cousin and her puppy on the hill by the zoo overlooking downtown when I started to experience pain in my side. It continued overnight, so the next day we decided I should go get checked. I've always hated hospitals. There's too much I don't understand, too much unknown, and I don't like feeling so dependent. Every time I visit someone in the hospital, I end up having to sit with my head between my knees waiting for the color to return to my face. The only exception was when my nieces and nephews were born and when Greg was there, because Greg could handle anything. Now as a patient myself, I was terrified. Lying in a hospital bed with my family there with me, I was coping with the physical pain, but completely reliant on them to advocate for me. Being there 4 weeks after we lost Greg was a heartbreaking reminder of how the system had failed us. We were hyper aware of every step we had to take, and we were constantly trying to anticipate where the next crack in the system would be. It was a constant battle. There was confusion around whether or not I had to have a CT scan. At one point, my dad had to fight to prevent them from writing a prescription and sending me home. In pre-op, a resident came in and asked my dad and I, "Has anyone talked to you about the mass in your bladder?" There were so many gaps and a total lack of continuity. We had already experienced the fact that the players don't communicate or work together. My inflamed, microperforated appendix was removed and I was referred to a urologist, but my story doesn't end there. I continued on, being passed through the system, hoping that I would be able to trust the next department more than the last. I wanted to respect the process, but knew blind trust in it is dangerous.
Wow, just about to get you. I'm so proud that you know.
How can I never see you again?
My sister Carol suffered some brain damage at birth. Growing up with a developmental disability in the 50s was hard. She struggled to belong. But when Carol finished high school, she was able to get a job sorting mail and working in a file room. She loved these years. She was invited to baby showers and lunches with coworkers and felt that she was part of a community. There were people who cared for her and she for them. After 23 years, this employment chapter of her life ended abruptly when Carol became ill. She was eventually diagnosed with a schizoaffective condition. It took several years for Carol to get stable, but she did. We found the right medications, a place to live, and programs. She didn't return to her old self, but she got on with life. And we found the Calgary Scope Society, and they became a second family to her. Staff for support and friends for all kinds of fun gatherings. They traveled together, and Carol had her community again. The last 2.5 years of Carol's life were very hard. After having emergency surgery, she developed infections and delirium. She was in restraints and became very anxious. Hospital admissions were ongoing. Her delirium continued, and with each admission, we seemed to lose more of her. To us, Carol was precious. She was one of a kind, loving and caring, funny, determined, and sometimes challenging. But her support staff valued the whole package and really cared about her. I know her condition was complex and demanding, but I'm not sure the hospital saw that we were part of the solution. In community, her support staff, medical staff, and family worked as a team. But in the hospital, she went from having one family doctor and one psychiatrist who were intimately familiar with her to having new ones every admission. Her psychiatric medication changes in hospital were frequent, abrupt, and the results unpredictable. I struggled to convey information about the changes I was seeing in Carol. At one point I said, "You are the experts in psychiatry and medicine, but we are the experts in Carol." On one desperate day, when Carol appeared to be declining and seemed to be having visual hallucinations, I explained this to a nurse who dismissed the observation. We knew we were losing ground, and we were frantic to help her. My sister died in hospital unexpectedly. We don't really know why. We heard stroke, heart attack, aspiration. In one sense, you could say it doesn't matter, but to us, it does. Carol taught me so much, just as big sisters are supposed to. I will always remember her generosity of spirit, care for others, tenacity, and good humor. I just wish I could have done more for her in the last years of her life. I wish I'd had a stronger voice.
These are tough to hear and watch. So it is now my pleasure to introduce our next keynote speaker, who will be known to many of you, Professor Art Frank. He's from here. He's a professor emeritus of sociology at the U of Calgary, where he's been since 1975, and he's also a professor at Britannian College in Bergen, Norway. He's a medical sociologist by training. He's an author of many books, including a memoir of critical illness, etc., The Wounded Storyteller, The Renewal of Generosity, Illness, Medicine, and How to Live, and other books. He's been a visiting professor in many places in the world, and he is an elected fellow of the Hastings Centre and a fellow of the Royal Society of Canada, which awarded him the Abby Ann Lynch Medal for Bioethics in 2008. And Art is going to talk to us about different decades, what has changed or not. So please welcome Art Frank.
Thank you, Stephen.
Thank you. Thanks to the O'Brien Center for hosting this event. And it's really exciting as a speaker to have watched this turning into kind of a, gee, I wonder what Ward Flemons has planned into what it's turned into today and what it may turn into in the future, which is what I want to talk about. I want to start with some questions of what patient-centered care is, what prevents patient-centered care from being practiced, and then how can the Imagine Project, which is why we're here today, move healthcare in Alberta toward becoming more patient-centered. So let me begin with a clarification involving who means what when people speak of care being patient-centered, or as some people prefer to say, family-centered. For patients and their families, what's involved in this phrase is, I think, the patient in the singular. Healthcare is patient-centered when it recognizes the particular needs of specific people, and when it's willing to adapt institutional procedures, protocols, to fit those individual needs. Over many years, a story has stuck with me. It's a parallel exactly to the story that Dave told about his emergency room experience with Greg. This was a story of some friends of ours years ago whose child needed surgery at the old children's hospital. And our friend has told this story herself publicly in rounds, so it betrays no confidences to tell it again today. In accordance with good patient-centered practice, the child was assured that her mother could go with her right into the emergency room and stay with her, holding her hand until she went to sleep. Children, of course, take such assurances very seriously. Children are learning about trust. That was the patient-centered ideal. When the child was actually being taken into the operating room, the surgeon told the child's mother that she could not go with her daughter, the simple reason being that it slowed down his schedule to have parents coming into the operating room. The schedule trumped individual needs that the surgeon understood perfectly well. Here we get to what it means too often to healthcare workers to be patient-centered. Now, the most serious, if perhaps overly generous, rationale I can concoct for that surgeon's behavior reflects something that was said to me, again years ago, at an annual retreat of a specialized medical unit that I was invited to attend. The unit administrator was acknowledging that the pace of their examinations and assessment routines were, and I think I remember her word correctly, painful to their patients. But then she said something that has stuck with me, obviously, all these years. She added, "We have patients who die on our waiting list." The reality of the waiting list, who else needs care while I'm spending time with this patient, is part of how healthcare workers need to live. It weighs on them. For professionals, then, being patient-centered means that the singular patient is known and served within an aggregate of patients. Here we get to what may be, in my observation, the most significant, actually, we can switch to this mic, and I don't need this one. What may be the most serious disconnection between patients and their families on one side and healthcare workers on the other. For patients and their families, almost any condition that's serious enough to warrant hospitalization is a crisis. How everyone acts in that crisis is going to be remembered. It will be told and retold in stories like the one I've just told you, in stories like the ones that you're seeing in the digital storytelling that you've just heard from Dave. The bioethicist William May once quoted a woman who he talked to after her husband had died very suddenly and far too young. This woman said that the question she faced was whether she could rise to the occasion that her husband's death had confronted her with. The question of patient-centeredness for patients and families is whether the institution helps them as they struggle to rise to the occasion of the crisis they face, or whether the institution sets obstacles in their way, as we've already heard. Meanwhile, healthcare workers on their side of these events have to go back to work day after day. And however seriously people take their work, it has to take on the quality of being a routine. What a crisis is for patients has to be another day's work for the medical staff. I emphasize that to keep going back to work every day, healthcare workers have to limit what they can allow themselves to see. That limitation of perception became most evident to me in a story told me by a friend who was receiving radiotherapy as adjunctive treatment for breast cancer. By trade, she was a performance artist. And so she decided to turn all of this into a form of performance, a photo documentary of what happened to her throughout treatment. That included photos of her chest and the progressive burning that took place during radiation until by the end of treatment, the skin was bright red and raw. To the credit of the nurses in that radiology unit, they did look at the photos with her. What fascinates me, and what I think has considerable implications for thinking about patient-centered care, is that these experienced nurses reacted to these photos by saying they had never seen the burning of their patients before. After all the patients who they had taken through this therapy, they saw the side effects only when they looked at the photographs this patient had taken of herself. That's what I mean when I say healthcare workers can allow themselves to see only so much if they are to keep up the daily routine of their work. These nurses were not in denial about the pain the treatment caused their patients. I think a better description is to say they were in a state of suspended perception. Patient-centered care begins by reanimating the perception that's become suspended. It's about freeing people to be able to see. What you're hearing in these digital stories, and you're going to hear it in the next one, they simply were not able to see despite the family saying, "Look, there it is." And over again, the stories we're hearing today is about the healthcare workers just not being able to see what was going on. So we have two versions of patient-centered care that emerge in these stories. Setting the bar low, patient-centered care means safety. It means clear lines of responsibility with access to whomever is responsible at that time. It means the collaborative efficiency that the Price family underscores on their website, which I encourage you all to look at. Setting the bar high, patient-centered care means what in my writing I've called generous care. It means recognizing the patient as a person with very individual fears and goals for their life. It means making that person feel welcome, what was satirized in Brian's wonderful tape. It means offering support to however that person seeks to rise to the occasion of his or her life. The low bar setting, I think most of us would agree, I hope most of us would agree, is the absolute responsibility, the non-negotiable responsibility of a healthcare system. The high bar setting is a possibility that is attainable. We'll hear more from Jim after I finish talking about the work at Dana-Farber to attain something closer to the high bar. My contention is that the low bar will be cleared only when the high bar is taken seriously as a goal, even if that goal can never be fully achieved. In the old days of the Calgary Health Region, which I know some of you remember, I was lucky enough to serve on a committee to improve what we called, in the title of our committee, patient experience. In some medical circles, it may be radical to take seriously that patients are not simply being treated, patients are having experiences. And the quality of that experience is a genuine goal of medicine in excess of the success of the treatment. One of the most useful days that our committee spent was when we made site visits to a couple of hospitals in Oregon and Washington that we had been properly informed were setting a standard for patient-centered care. I had pretty much given up thinking that hospitals could be like the ones we found. What first impressed me in these hospitals was their quiet. There was no din of voices shouting to be heard over other voices that were shouting to be heard over loudspeaker announcements. Then I realized how uncluttered their hallways were. That moving from one area of the hospital to another was not an obstacle course, it was actually relaxing. It provided a moment when you could come down a little bit between what you were doing in those two places. The staff were continuously cooperative with each other. I remember one nurse we talked to saying that if her unit was busy, she didn't panic because she knew someone from another unit would come over and help her. And if they were a little slack, she would go to where a unit needed her help. Staff felt supported by each other, and they felt supported by the hospital administration. Much more could be said, but sufficient for now is the message that the hospitals we visited seemed to be open places. An example of how physical spaces were open is that the plexiglass walls around the nursing stations had been taken down. There was just a desk. It was sitting there, accessible. But openness was also about information. This hospital practiced open charting, offering patients and their families full continuous access to all of the medical information. Obviously, much more needs to be said about how these changes had come about. They didn't happen overnight. In order to make these hospitals into the places we observed. My point for now is only that such places are not a fantasy, they actually exist. With these stories in mind, I turn to this new commitment to patient-centered care, sponsored by the O'Brien Center, and we hope fully embraced by Alberta Health Services. A story of my own hospital experience can serve as a cautionary tale of what to avoid in Project Imagine. This story is about a half-baked attempt at being patient-centered, and why, if you don't have time to ask Albertans to, quote, have their say about health care, it may be better not to do it at all. Exactly 21 years ago, I was having one of my annual follow-up examinations for signs of recurrence of cancer. This exam produced the most serious among the several false positive results I'd had over the years I was being followed. Initial x-rays showed nodes on my lungs and my diaphragm, and these were later confirmed by a CT scan. Recurrence of cancer was strongly suspected, but I needed a mediastinoscopy to biopsy one of the nodes for confirmation. For those of you who are not medical, that's a scary surgery. It involves passing an inflexible tube through an incision here down behind the breastbone. Not a place you want to have investigated. Don't do it. The day before this surgery, I went through a series of preoperative tests at Foothills. In one of these encounters, I was alone with a nurse who asked me several questions that were routine about my health, until her last question surprised me. She asked how my wife and I were dealing with the possibility that I might have cancer again. The truth is that we were doing very badly. Our daughter was not quite a year old. My wife was still recovering from extremely difficult pregnancy and delivery, and I was struggling to put back together an academic career that had been derailed by having cancer What I had to decide very quickly was how much of that to tell to this nurse. In part because we were in a private setting that was actually appropriate for discussing such personal issues. In part because the nurse seemed like a mature and competent professional. And in part because I was feeling frighteningly alone and I needed somebody. I decided to tell her the truth. I said we were doing very badly, and I waited to see how she would offer to help. She frowned, muttered something about how we needed to talk to each other more, and walked out of the room, leaving no space for me to respond. Then I felt truly alone. The obvious take-home message of this story is that it's a bad idea to ask someone a question about their needs if you're not prepared to offer a serious response to whatever that person may tell you. And that message becomes magnified in proportion to how personal the question is and how much is expressed in the person's answer. The nurse's probably scripted question was somebody's idea of, gee, we ought to be patient-centered. Let's ask how they're doing. But the question was asked with no resources to actually back it up. As it was asked and then not acted upon, the question was nothing more than the hospital trying to demonstrate to itself how extensively it cared. A public event like today that invites and encourages talk about how care can be truly patient-centered. And beyond today, the extended project that the O'Brien Center is undertaking should be dangerous because they arouse expectations. If those expectations are not met to some degree, if real visible changes do not occur in response to questions that are asked and invitations that are made to contribute, the public has every right to retreat into cynicism. Those who do tell you their stories can and should feel set up if Project Imagine proves to be only a public relations exercise, like that false, dead-end pre-op question was to me. Asking Albertans what they want in their health care is especially dangerous because we can pretty well predict in advance what they want. People want to avoid having to go to emergency rooms because instead they want to be registered in a primary care practice that offers reliable after-hours responses, one of the points you've already heard from Dave Price. If they do go to an ER, they want to be seen quickly by a triage professional who can either give them an accurate time estimate of when they'll be seen, or if they don't need to be seen, as many don't, can give them a follow-up appointment on an outpatient basis. If people have to be admitted to the hospital, they want to be put in a room, not left lying in a corridor. And following a different pathway, when a patient is referred to a specialist, something we've heard a lot about in Dave's presentation, the physician making that referral will be clear how long a waiting time is safe and will remain responsible for care until the patient is seen by that specialist. No primary care patient wants to be told, as Terry Price was in the story you just heard, that their physician faces an impenetrable subspecialist system and the best advice is to go camp out in the emergency room until somebody finally sees you. Take your sleeping bag and your chocolate bars and just wait. Nobody wants to see their physician be that powerless in the face of the system. And yet none of these conditions is met by current health care in Alberta. You don't need public consultation to know that these basic and eminently reasonable demands are what people want. You also don't need public consultation to develop a healthcare to-do list because you've already got the Flemings Report, which, if you haven't read it, is available online. It details the story you've already heard. It looks at the medical systems that need to be implemented to do what the Price family is recommending. Its recommendations are clear, reasoned, substantive, undeniably valuable, and they haven't been acted upon. The serious question we have to confront today is why, instead of taking the Flemings Report seriously and getting to work on implementing its recommendations, we're asking people for more ideas. My best response to this non-rhetorical question is to quote a line spoken by the great actor, the late James Gandolfini, in what was sadly his last film, Enough Said. In the plot of the film, the woman with whom his character has enjoyed a developing romantic relationship has done something very unfortunate. She apologizes, saying she just didn't know what to do. You knew what to do, Gandolfini says. You just didn't do it. That line could apply to the nurse who asked me how my wife and I were doing with the threat of imminent critical illness, and then walked out of the room when I gave her the wrong answer. Either she knew what to do and didn't do it, or else she should have realized she had no business asking the question at all when she had no resources to follow it up. Far better if she had only said something like, "This must be terribly difficult for you and your wife. I'm sorry. I hope somewhere you get the help you may need." That would have closed off her own responsibility, but it would have made me feel that she actually saw what was going on. It would have also, though, required an honest admission of the hospital's institutional limitations. And my observation over the years is that institutional medicine has a very serious problem admitting its limitations. That problem then often comes down on patients who think they can expect something the institution knows it can't deliver. How then can the Imagine Project not only know the right thing to do, but actually do some of the right things? I want to offer 4 principles that I hope will guide this admirable initiative. These principles are mutually supporting and they are overlapping. My first principle can be called responsible response. If public input is requested, then there needs to be ongoing public accountability of how Alberta Health Services is responding to what the public says. I suggest taking one idea a month from this public consultation exercise, one idea a month, and tracking its progress toward implementation. That tracking would make it clear if some particular group is blocking the progress of implementation. It would show the public exactly as possible at what barrier the implementation process has stalled. AHS almost never acts alone. It necessarily acts in cooperation with professional groups, government groups, and private groups. These groups might act differently if their cooperation or lack thereof was being publicized as the point at which some initiative had broken down. My second principle can be called small and specific demands. I worry when phrases like transformational change start being tossed around. In my view, the last transformational change in Western medicine was the Flexner Report 100 years ago. The history of medicine since is littered. They occur just about every decade on a major basis, with well-intentioned initiatives that have generally produced very little results. They recycle the same issues and criticisms over and over again. My sense of the public mood is that generalized skepticism is one of generalized skepticism about the healthcare system as a whole, tempered by incurable optimism that somehow I or my loved ones will get the care that we need when we happen to need it, even though I know the system has all these troubles. People need to believe that. Many of the stories we've heard today testify to the limits of that individual optimism. The Alberta healthcare system is huge, it's disjointed, and it's wildly uneven in its capacities. Transforming the whole is not on any agenda that I can imagine. What I can imagine is starting with small, reasonably cheap, measurable improvements that, because they are specific, require changes in attitude. Especially small changes require people to think less in terms of institutional convenience and instead orient toward respecting patients' time, respecting their fear and suffering, respecting their dignity. Open charting is a small change. It's not transformational, but it would mark a significant shift in attitude. And when a number of significant shifts in attitude aggregate, then the system begins to change substantially. So we have responsiveness and we have small and specific. My third principle is reciprocal benefit. I remember once lecturing on the usual kind of ideals I spout off on about doctor-patient relationships and what they could be. And a physician in the audience who's written some fine work that I admire said, both ironically and also very sincerely, because he practices medicine, "Don't ask me to do one more thing." Healthcare workers are already overloaded. That needs to be clearly recognized in whatever is advocated. One of the most evident features of the hospitals that the old CHR committee visited years ago was how relaxed the staff appeared to be. They not only seemed to take pride in their work, they actually looked like they took pleasure being in the hospital. Leadership, which is a crucial word that I've delayed too long bringing into this talk. Leadership needs to show healthcare workers why these small specific changes will actually improve their working conditions and their job satisfaction. If people are expected to do more in the cause of being patient-centered, and very often they are, they not only need the resources to do what's required, they also need to understand and appreciate the benefit of that change. I'm thinking of the terrible story of the woman abandoned in her urine-soaked bed while in her report the nurses went off and had a birthday party. And I'm asking myself, could they possibly have had a good time because they had to know in the back of their minds what else was going on? Or is this the dance band on the Titanic? I think too often what runs medical workers down is that they know they're not doing the work that they want to do and could do. Medical staff need to, as I say, not only have the resources, they need to understand the benefits. They need to understand that a patient-centered institution is a better working environment for everyone. And that brings me directly to my final principle, which I call Reiser's Law, because it follows a statement about medical education made by the physician and medical historian Stanley Reiser. Reiser was writing specifically about residency training, but he made an observation that I believe should organize medical work at all levels. Teachers, he said, should treat students as they wish them to treat patients. That applies to how everybody treats everybody else. To paraphrase a more famous medical aphorism, the secret of the care of the patient is making staff at all levels feel valued and supported. And Dave has already talked about how Alberta Health Services has a very questionable record in that department. I say that because I can say these things today because the leadership has changed very recently. How this new leadership, from the minister on down, treats its employees will demonstrate how it expects those healthcare workers to treat their patients. Medicine is hierarchical. Things go downhill. Because I absolutely believe Reiser was right. At any level of staff, no one treats the patients better than they themselves are being treated. Those staff who do heroically treat their patients better than they themselves feel treated end up burning out and leaving the system. And honestly, over the years, I've had so many conversations with people who were my hosts at events that have invited me in, people who over several days I came to admire considerably as exemplars of what healthcare work should be. And then toward the end of my visit, always seems to happen when they're driving me back to the hotel at night, they'll say, you know, I'm really thinking of leaving medicine. I don't know if I can take it. You can't lose those people. You can't lose your best people to burnout and demoralization. And patient-centered care ultimately is about the best people on the staff side. It's not just about the patients. When Albertans have their say about healthcare on the Project Imagine website, there is a great deal that we can learn from the comments that are entered, the conversation that ensues. But at the end of that learning process, the question will not be whether we have learned the right thing to do. The question will be whether there is the administrative leadership to do that right thing. Thank you. I'm just going to introduce Deb's story. We now have a digital story from Deb Prowse. Deb, I'm glad to say, is here. She'll be participating in the panel discussion at the end of today. And like the Price family, the Prowse family has chosen to turn a personal tragedy into a great public service. Deb's story.
Mom, I still remember the bright sunny day in March when we sat down to discuss what you wanted to do about what happened in your healthcare experience 3 months earlier. We girls had discussed the situation, but we were putting it to you for the first time. Do you want to file a statement of claim? You didn't remember much about what happened, but 24 hours after your hip replacement surgery at the Rocky, you bled out in the ward and had a heart attack. We had tried very hard to raise an alarm about your condition. Those of us at your bedside saw your deterioration that morning, but the nurses either couldn't see what was happening or didn't have a way of responding that would help you. You didn't know that we were threatened with criminal charges for upsetting the nurses by advocating for you. Then a surgeon arrived, saw that you were dying. You were moved to the ICU unit where you stayed for 12 days. The last few months had been really hard on us because nobody talked to us about what happened. There was no acknowledgement that the staff should have listened to our concerns about you, no apology for the harm you suffered, and no assurance that this would never happen again to another patient. And that led us to our discussion. Given all the lawyers in the family, You knew commencing a lawsuit was not out of the question. We could write a statement of claim over breakfast any day, but suing someone was not to be taken lightly. Why were we put in the position of having to take this extreme step to get information and to get them to take responsibility? You were very thoughtful about this. You were upset at hearing how you and the rest of us had been treated, but you said, "I'm getting old and I will need more health care in the future. I don't want there to be a black mark against my name that would prevent me from getting the care I need." So we did nothing. Almost a year later, you died. This time we had disclosure with the Health Region's executive team. There was acknowledgement of what happened, an apology, and there was a promise that action would be taken to prevent this from happening again. I remember at one of the disclosure meetings putting my hand on the CEO's suit lapel and saying, "Please don't make us sue." We didn't have to. As I look back now after 10 years, I can assure you that your death was not futile. You have had quite an impact in many ways, but I'm concerned that we have lost some ground lately and need to once again ensure that patient safety is a priority before anyone else dies. Love you.
It's now my pleasure to introduce our last keynote of the day before we get into the panel, and I'm delighted to introduce Jim Conway. He's an adjunct lecturer at the Harvard School of Public Health and senior consultant on safe and reliable health care in Evergreen, Colorado. He's had a long and distinguished career as an administrator. He's an expert and an honoree in developing patient-centered care. He spent 10 years as the Executive Vice President and Chief Operating Officer of the renowned Dana-Farber Cancer Institute in Boston. And when I tell you he's from Boston and you hear him talk, you won't dispute the fact. So please welcome Jim Conway.
So were you suggesting that I have an accent? Thank you. Because of leaders with names like Ward, Sharon, Chris, because of patients and family members like Deb, Sabina, and Matata, people who I've met before in this extraordinary community, there was only one place I could be. And today I am overwhelmed at the privilege that you have given me to be here. I talked about that privilege on the radio this morning. The extraordinary privilege of not starting a journey because you have such amazing work going on. But I told somebody earlier today that what you've been working on is threads. What you have to do now is build the fabric. You have to put it all together in a way that's going to drive the changes that we seek to achieve. So I am going to talk about a report on my journey and some organizations' journey in patient and family-centered care. I am going to discuss how I, as a leader, an executive, I'm one of those people who takes away your space, who makes you park so far you have to pack a lunch. How did I discover the extraordinary power and privilege of patient and family-centered care? In the pictures that are on that slide, the first one is patient and family-centered care is in the garden. It's in the home. It's in the boardroom. This is the boardroom of Dana-Farber Cancer Institute, where patients and families were participating in discussions. Because as we talked about since 1996, you could not have a discussion about care without having the recipients of care as part of the discussion. It's that extraordinarily privilege that those of you as clinicians, in this case Lewis with this child, have in your amazing practice. Patient and family-centered care's potential exists in every clinic, in every examining room, at every bedside. This is in the adult clinic at Dana-Farber with Maria, a nurse, and one of her patients. And the last is a bronze of the Walter Reed National Medical Center in Bethesda, Bethesda, Maryland. As you walk in the door, you see this striking bronze of a soldier carrying a wounded person. That's the extraordinary privilege that we have of patient and family-centered care. What I'm going to talk about in the time I have, and the timekeepers can jump up and down to say, shut up, I am going to talk about my journey. It will be extraordinarily hard to believe because I look so young, but I am approaching shortly my 50th year in healthcare. Very good, you suck up to visitors, real good. Talk about my starting Children's in 1966, Dana-Farber in 1995, and then talk about where I am today as a trustee, as an academic, as a patient. I have diabetes. I have something called cervical dystonia. Some people believe my no-no tremor is after 50 years as an executive saying no-no. That's a horrible rumor. And I'm also going to embed, as I become a frequent flyer in my healthcare setting, some of my experiences, and then how we talk about moving forward. I first, again, want to congratulate you on your work. I want to congratulate you on the exceptional care and caring, the hope and discovery that goes on in your healthcare settings, whether they be at home, in the kitchen, the bathroom, the bedroom, or in a care setting. I want to congratulate for the extraordinary contributions as a community you are making. And as the world focuses increasingly on the role of patients and families in population health, this intervention, which you imagine could become a defining content lead in understanding, so how do we do this as a province? How do we move a province on this journey? I also do this for something else that we've already talked about. As I've traveled the country, I've met clinicians who tell me that nobody ever thanks them. I was at a meeting recently where a nurse stood up, looked at her chief nurse and said, I've been reporting for you 10 years, never once have you said thank you for my practice. And it's not that we don't have extraordinary work to do, but I committed, as I was crisscrossing the world with IHI, to never again show a PowerPoint deck without, within the first 4 slides, thanking those that I was privileged to be addressing for their exceptional practice. You know, what we're discovering is in the gap between excellent and perfect is suffering, harm, tragedy, and death. And that's the journey we're on, and we have to stop and acknowledge that. So in the early 60s, I began working at Children's Hospital in Boston. It was about time, the time that mothers were saying, you do understand, for those of you who are younger, that if your kid was in the hospital in 1960, you went home most of the time. If your kid was overnight, you said goodnight at 8 o'clock, and in many places could not see them until 2 in the afternoon. If your kid was in an eye in your lung in the 50s, you were able to see them on the weekend. The 50s. So in the late 60s and 70s mothers began to say, I don't care who you are, I'm going to stay with my kid. I'm going to be with my kid in the x-ray room. I'm going to be with them overnight. I'm going to be with them in the examining room. I, as a young administrator, discovered there is no force in the world stronger than a mother in my face advocating for her kid. And in that process, I discovered and began to discover the exceptional privilege of patient and family-centered care. In the 1970s, the Children's Hospital in Boston began its first Parent Advisory Council. Was it hard? You better believe it. Was it scary? You better believe it. Did we learn things we never knew every time they opened up their mouth? We learned things we didn't know. I also, a little bit later, learned that just because you're poor doesn't mean you're stupid. I had a mother tell me that one day as she was trying to understand her child's condition. And far too often we trivialize the place people come from as they come to care. So from 1966 to 1995, I worked at Children's as an exec and an administrator and a clerk, and I discovered this exceptional privilege. In 1995, I was invited to go to the Dana-Farber Cancer Institute at a time of horrible tragedy. We had just killed the wife of one of our cancer researchers, the Boston Globe journalist, Betsy Lehman. We did it with a 4-fold chemotherapy overdose. And the organization did something exceptional, driven by the Board of Trustees, not by leadership, but by the Board of Trustees. The Board of Trustees said we had a moral and ethical responsibility to disclose. Did most organizations in 95 disclose? No. Many still don't disclose now. What they would do is fire a few staff, rewrite a few policies, and pledge that it would never happen again. They would use expressions, we can't be perfect. Cancer patients, you're almost going to kill them to cure them. But the Board of Trustees said we had this responsibility to disclose. One of the unbelievably tragic parts of Betsy's death, the lead reporter at the Boston Globe on Health, the wife of a cancer researcher, for 3 weeks before her death, she was trying to get our attention that she was having an atypical response. We blew her off. What does she know? She didn't have a PhD. She didn't have an MD. What does she know? We patted her on the head, but we as an organization totally ignored the voice of the patient. what we learned, and this is an article that we wrote from the American Society of Clinical Oncology on what we learned from the Lehman overdose. And I'll touch on it because patient and family-centered care is part of a much larger fabric. It's of a piece. What we learned that has already been talked about is the exquisite responsibility and power of leadership over quality and safety. The people who worry about money, the people who worry about strategy, the people worrying about markets also have a fundamental responsibility. When I was hired by the Dana-Farber, my second last interview around the offer was the chairman of the board. Then put his finger up to my nose and he said, "Never again." The first reason for never again was never again would we kill a patient. The second never again was never again would the Board of Trustees be duped. When the 35-page report came from with the recommendations from the accrediting bodies, nothing in that report was a surprise. People, it's close to the work. It's the world you lived in every day. But everything in that report was a surprise to leadership. The second is the need for relentless vigilance to quality, safety, harm. You know, I was struck at listening to Art's talk about what we discovered, and NASA actually taught us. We discovered something, the reason people don't see things, or the reason people just are oblivious to things, is because of something NASA taught us is called the normalization of deviance. You know, you see stuff and you see it, and after a while you just don't see it anymore. It's a survival strategy, and it's so much more. We learned about addressing the multiple victims of error, not only the patients and families, but also the staff. The last thing that they wanted to do was to hurt that patient today. We learned about the crucial role that systems played. One of my mantras at Dana-Farber is, our systems are too complex to expect merely extraordinary people to perform perfectly 100% of the time. We as leaders have a responsibility to put in place systems that support safe practice. What failed Betsy Lehman and her family was the failure of governance and executive leadership putting in place those systems. We expected you to be perfect 100% of the time, even though everybody knows that no matter how good you are, you can't be perfect. We learned about the synergy of interdisciplinary practice. When I came to Dana-Farber, I said we had virtuoso nurses, virtuoso pharmacists, virtuoso physicians. We had no conductor, we had the no score. We let the organization chart get in the way, and then the last and most important was the power of patient and family-centered care. We had to blow out of the water our response to patient and family-centered care for a number of reasons. Let's talk about definitions just for a moment of patient and family-centered care. The first is it's anchored in dignity and respect. Providers listen and honor patient and families' perspectives and choices. This isn't cookie-cutter work. This is honoring and respecting patient and family-centered care. The last time I was here, I gave many of you a lecture on the most important things I've learned in my career. Nothing is more important than respect. Respect of our patients and families, respect of our staff. The second, it's information sharing. Providers share complete and unbiased information in ways that's useful and affirming. My friend Carol from the United Hospital Fund took care of her neurologically devastated husband in her home for 17 years. She said, Jim, on Wednesday night, we're in the ICU. 40 people are taking care of him. Friday night, we're in med-surg unit, 10 people are. Sunday afternoon, we're in the bed in the dining room. It's just me and him. How have we provided Carol the information that she needs to care for her husband in a way that respects all that their relationship means to them? It's participation in care and decision making. A few years ago, had a wen on my neck, a big one. As a typical Irishman, I waited the mandatory 6 months, hope it would go away. I caved into aggressive home advocacy and went to have it removed. And it was at the BI Deaconess, and the surgeon and the nurse came to see me before my procedure and said, "Jim, we understand you have cervical dystonia. Can you tell us about the dystonia? And can you tell us about how best to immobilize your head?" I was blown away that I was being invited into my care. I know a lot about my no-no tremor. I know a lot about it. And it's about collaboration in everything we say and do. So Dana-Farber's tension for change, Kingston, which we've heard about, had an extraordinary tension for change. And Dana-Farber's tension for change is we had to respond to a horrible, tragic event. How do we listen to patients at a distinguished academic institution? How do we listen to patients and families when they raise their hand? The second is we were merging the cancer programs at the Dana-Farber and the Brigham. Dana-Farber hated the Brigham hated the Dana-Farber. Our patients thought they were alive because of the Brigham or the Dana-Farber. And when we talked about merging their programs, they looked at us and said, "You're playing around with my life. I'm alive because of the Brigham. I'm alive because of the Dana-Farber. You can't make this change." And then a CEO and a chief operating officer who came from the world of pediatrics were blown away that we couldn't find where the patient was or the family was in adult care. We were so used in pediatrics to the partnership. And we, as we kicked off this dramatic transformation focused on the areas we just reviewed, we said, how do we know what makes sense to patients? So what we did is, this isn't about surveys, it's not a focus group. We said that we had to establish a BHAG, a big, hairy, audacious goal. That's MIT. Every once in a while, Harvard goes to MIT. That's MIT talk. That's a big, hairy, audacious goal. And our big, hairy, audacious goal was that patients and families would populate all of decision-making bodies and structures of the institution. We got leadership buy-in. This wasn't put to a vote. We didn't wait for everybody to buy in. The governing board and the executive leadership said, "You will." And then we got some help, and we've heard about that also today. Our form of help is we set it as an institutional goal, and then we told people. Often people set an institutional goal, but they don't tell anybody just in case they don't achieve it. We set it as an institutional goal. We publicized it. We retained the Institute for Family-Centered Care, which they were called to come in and help us. And we appointed leadership. And the thing that we did about leadership, and it's going to be a very important thing that you have to confront, is this isn't the purview of patient relations and social work. This is the work of the chief medical officer, the chief nursing officer, the leads at the clinics. At the end of the day, we have to impact the way we do the work. And the only way we're going to do that is by engaging at a leadership level the people who can control and very significantly influence the way we do the work. And it respects the reality of where most of the work gets done. The CEO and the COO had to be visible but not consuming, because we also couldn't get in Larry and Susan's way as they were leading this journey forward. Then we got ready to hold on. We started, one of the things we know is the reason people don't go there is because they're petrified about what it looks like. It's very hard. So we had Bev Johnson came in, interviewed all of our senior staff about what they were losing sleep over. We then had invitational meetings for patients and families, telling them what we were thinking about. The first meeting, about 10 people showed up. The second meeting, about 10 people showed up. The third meeting, 100 people showed up. We had to move it to a different location, but the remarkable thing that happened at that meeting, we put together a brilliant meeting. Bev was facilitating it. We had all of these speakers, and about halfway through the meeting, a woman raises her hand and says, "You ask us what we think, but you don't shut up long enough to listen." So we asked them what they wanted to talk about. They wanted to talk about pain. They wanted to talk about feeling abandoned at the end of life. Not the refrigerator orange juice, not the colors of the walls. And Susan Grant turned to me, she was the chief nurse at the time, and she said, "I don't think things are going to be the same ever again." And I said, "Susan, thank God they weren't," and we were off and running. Year 2, we elected a committee. They reported into our QI structure. We quickly moved from complaining to problem solving. We had to deal with a lot of issues. We published our first newsletter. So a lot going on. What did staff think? Their reaction was surprisingly good. Because what they found in the process is they were learning all kinds of things they didn't know. Were there some people who said, "You're certifiable, you want to do what? You are crazy, you have absolutely lost it, not my program." Sure. In one of the hiccups we made in the process is we spent a lot of time in the beginning orienting all the staff, but we forgot to orient the people who were continuing to come over time, to our expectations. What was my reaction? It exceeded our wildest expectations. The staff response was amazing. We had 134 patient and family advisors at the time. There was unbelievably striking learning. We were seeing the work replicated in other facilities. We were invited to the White House to share what we were doing. There was a caution, a tremendous caution in the beginning. People thought this was all about PR and spin, and we really had to navigate that very clearly. And also to realize this isn't plug and play. Once you start, you've just started, and the need to constantly stay on top of it. So this is when people talk at Kingston about what the activities look like. This is what patient and family-centered care look like at Dana-Farber, just some of the activities that patient and family. You could not plan a clinical space without having patients and families on the design team that planned the space. Never again. Tons of benefits. You can read through these at your leisure. In my interview this morning, I was approached about cost. They saved us a boodle of money in all the waste, in all the inefficiency, in the far better use of fixed assets. It was an extraordinary gift. We had a very positive differentiation of the system. Again, this wasn't plug and play. We had to work with everybody to position them for the success. One of the things that I've learned as a leader is you have to set an expectation, you have to position people for success, you have to hold them accountable. We had to do all of those. And you can go through and read those individual pieces. Were there challenges? Absolutely. This is not work for the meek. If you went into this job for applause, you made a horrible mistake. But it is relentless work, and these challenges can be overcome. What were the outcomes? An extraordinary sense of pride over the practice. We were improving all kinds of things that we never imagined. It was growing our evidence base and so much more. Today, patient and family-centered care is no longer an if discussion. Worldwide, it's becoming a when, where, and how discussion. For the p-value crowd in the United States, the Institute of Medicine has reported unequivocally that patient and family engagement improves outcomes. There is no question at all about the work. Ross, patient and family-centered care now is also going on in the community, in the organization, in the microsystem, and in the experience of care. The reason I have a piece of fabric up there is to remind you each of these individual things are a thread together, so there's no premature declaration of victory. We had one PFAC in pediatrics, we're done. No, that's a piece of a piece. There's wonderful publications coming out in the very academic health policy literature talking about the power of patient and family-centered care. Many of you are on a high reliability journey, and what we are seeing as we take and apply Carl Weick and Kathleen Sutcliffe's definition of mindfulness to high reliability, patients and families can make an unbelievable contribution. We also, what's very clear as I bring this to a close, is that people are understanding that the elegant dance that goes on between clinical, financial, service, and experience outcomes. Patient family engagement can help you clinical, can help you financial, can help you service. In my state, it's now the law. A citizen initiative made patient and family advisory councils mandatory for all hospitals and healthcare facilities in Massachusetts. Don't like it? Suck it up. What you can do is click on this hyperlink, and that is an annual review of all of the activities of all the patient and family-centered care advisory councils going on in the Commonwealth of Massachusetts. It's stunning work. This is not a journey you're alone in. In Canada and around the world, there is an unbelievable community working in this space that you can steal shamelessly, draw courage from, and advance the world's journey. One of our cancer patients at Dana-Farber, who went on to become a lead at IHI, Martha, who had 3 cancers in her life, said to me, "Jim, you used to do it to me, then you did it for me, now you do it with me. I love where we are today." And what I want to do is end with a very important quote in my career. It was stolen from Avitas Donabedian, who taught us about structure, process, and outcome. Avitas also talked about first comes love and passion, then comes strategy and tactics. What the gift is, I think, we have in the space for the clinical community is our clinicians got into this space and administrators because of love and passion. And if we fuel that love and passion and build on that strategies and tactics, we can be brilliantly successful. But if all we do is a whole bunch of strategies and tactics without grounding in love and passion, we won't get to where we want to do. And with that, I'll end and just tell you that there's a bibliography at the end with further references on what leading edge publications are in this space. So thank you very much.
Well, thank you very much, Jim. That was a fabulous way to end the formal presentations from the speakers. And now, in the interest of time, we're going to leap into the panel. You're going to get a 2-minute stretch break. We want the speakers and our 3 panelists, Charlie Fisher, Deb Prowse, and Rick Ward, to come up to the front. We need to rearrange these chairs because this is not a panel. This is a little too distant. So we're going to move these 3 over somewhere in here, make a little bit of a semicircle, and then we'll get down to business in about 2. So. Testing. Okay. Folks, if you could take a seat, we've got to get this panel done by about 5:20, so we want to get lots of time in. So this is going to be where we draw this to some sort of moving forward conclusion. We want to tease out what you think the main questions are, whatever your suggestions are for moving forward to make this real. We are joined by 3 other panelists. I'm assuming your memories are sufficient that you remember the speakers. And our 3 additional panelists are Charlie Fisher, who is right here. Charlie is the retired president and CEO of Nexen, and you heard his story earlier today, patient advocate and co-lead of the Imagine Project Committee. Deb Prowse is well known to many of you. You heard Deb's story also, and she is also the first permanent Alberta health advocate. And Rick Ward is a community-based family physician at the Crowfoot Village Family Practice, where he's practiced for the last 25 years. So I'm going to start by asking the 3 of you who have not had a chance to speak today for 1 minute of your major impressions of what did you hear today. Give us a take-home, give us a kickstarter of the conversation. Deb, why don't we start with you?
Thank you. What really struck me was in the opening presentation around listening. So much of this starts with actually listening. The other concept that really stands out to me is partnership. My question is, how do we create a useful, positive partnership? I think that is really important to me. And my view is that for many years, we have heard what patient family-centered care is from providers. And how do we capture the patient perspective in defining that? And I think that is really important.
Great. So over to you, Charlie. Supposing you were trying to do the equivalent of patient-centered care at Nexen, what would you do?
Well, I was fortunate because I had great people that worked for me, so I could have started with a good idea and they'd have figured out how to do it. But I agree with what Deb was saying. I got started on all this because I spent a lot of time for 2 years in the system, and I just kept looking at the system. There were wonderful practitioners in the system with good equipment and good facilities, but the patient wasn't the priority. And so I guess I don't know when to stop, so I found some people to help me on this journey, and that sort of led ultimately to where we are today. But the system was created for the patients. If there weren't patients, we wouldn't have a healthcare system. So I really struggled with how did the patient not be the priority? So there are parts of healthcare where the patient's priority, but there's a lot that aren't. And we heard a lot today very specifically tied to physical institutions, largely AHS institutions. I think the issue is broader than that. We don't have an integrated health system. We've got family doctors in the community. We have institutions. We've got long-term care. And if you're trying to navigate as a patient between these things, good luck. And so for me, these are just challenges. This is a first world challenge because we have the expertise and we have the infrastructure. What we need to do is figure out how to provide the best care that we can to patients, because at the end of the day, it's about the patients.
So Rick, you've heard a lot today as a family doc. You've heard that in some ways the system doesn't allow you to be normally decent in your interactions because of the way it's designed and structured. You've heard of the navigation problems. You've heard all of these things. So you're at the leading edge of trying to reform primary care to make it more patient-centered. What have you heard today that inspires you, and where do you think we're making some progress? Do you want to pass it?
Yeah, so I guess what I would say is that most of the examples that we heard about today were when patients hit the system, they hit the tertiary care system, they hit the hospitals. What we know quite clearly is that a strong primary care will actually prevent a lot of those downstream problems. So when we're looking at the direction of primary care now, we're looking at creating patient-centered medical homes. We're looking at attachment. We're looking at continuity. We're looking at having a primary care provider, nurse practitioner, family physician who can walk with you on the journey, who, when you get discharged from the hospital with all those questions, is a home that you can go to get the support, to get the caring, and to get the continuity. And I'm happy to say that in Alberta, I think we're making some great strides in that direction.
Great. Ladies and gentlemen, the floor is now open. There are people, if you've got the mic in your hand, there's a couple circulating, so raise your hand. And, well, all takers, I have no idea what order you raise them in, so you guys will figure that out. And then just, you have a comment or a question, please try to be brief so we can get the most in. And if you have something specific per particular panelist, please identify that person. Yes, go ahead.
Okay, my name is Dr. Virginia Vandal Walker. I'm the patient engagement platform lead for Alberta Health Innovate Solutions. My question is, where is the nursing faculty and the nurses and the allied health professionals in your Imagine project?
Well,
I'll comment, but there are two experts sitting across from me, and they can rescue me. We started this, and the intention is to be wholly inclusive, because we're not going to get cultural change, behavioral change, unless all stakeholders are engaged in a process. This was just a launch, and it wasn't to exclude anybody. It was a launch to start a discussion, recognizing that all stakeholders have to be engaged in the process as we go forward. So I think, as Jim said, you need to have strong leadership that directs some of the things, but until you get internal participation and internal buy-in from the people at the front lines, you're not going to make very much headway. So there's no intention at all to exclude anybody. The intention today was just to start the process and to identify all the people that are going to need to be involved. But we also think it's important that the citizen voice be very, very strong as we go forward, because healthcare is about the patient, and we are all going to be patients. If not today, then on another day. And so we need to take any of the conflicts, or as many of the conflicts, off the table as we can, so when we come together and talk about these things, we talk about solving the problems of making the system better, as opposed to dealing with sacred cows. Like, I don't know what the sacred cows are, and I don't care. I just want to make the system better. So the nurses clearly have to be involved, as do probably others that aren't here today. I just don't know who they all are.
Hart, did you want to say?
I think one of the, I'm really view with horror the American healthcare system, because I have relatives there and I see what they go through. But you can learn things. And one of the things that I think they're doing much better than it's happening in Alberta is nurse practitioners at the subspecialty level. That when one of my elderly relatives is referred to a subspecialist, they're seen within a couple of days, much faster turnaround. And the uniform comment that I get is, I'd rather see the nurse practitioner. I hear that over and over again. The nurse practitioner then provides what Rick was calling the medical home at the subspecialist level. They would call them advanced practice nurse practitioners. We have a nurse practitioner presence in Alberta, but it could be vastly expanded, and it could do an enormous amount to solve the waiting list problem that Greg Price's story so sadly underscores.
Next from, yes.
Good afternoon. My name is Louise Bredner, and I'm an interested citizen. And I've spent way too much time visiting friends in hospitals in the last year. So someone, I think it was Art, that talked about the low bar and the high bar. And KGH, Kingston General, seems to be pretty darn close to that high bar if they haven't jumped over it. And my question for Dr. Goldstein is, How many health systems across Canada are banging down the door there to find out what they're doing instead of having everybody try to replicate the wheel?
Well, I think that it's a testament to the passion and the articulateness and the program that's being done, the articulateness of Leslie Thompson, that she's asked to speak everywhere, and is spreading her message everywhere. I will caution you about one thing. These are early days in the patient engagement experiment at KGH. And one of the things that I think is worth saying is that it's very easy to pass through the cathartic phase of people telling their horrible stories. Where the rubber meets the road is later, when the systems are in place, how they handle the next wave of complaints, because there will be. And it should be part of a process of continuous improvement. And to get to that headspace, you have to change the culture, that the culture that says we are all perfect and we never make mistakes. And so when there is one or a series of mistakes, there's revulsion and shame, as if to say, how could this be? These are outliers. Let's get rid of them. And to develop a process to have a place where people in all walks of the hospital life feel comfortable pointing things out when things don't make sense, because there's often a lot of eyes and ears. One of the things that wasn't talked about, there's often a lot of eyes and ears on the ground that by the by thought, gee, that looked weird. You know, maybe Brian was tired last night, or, you know, that didn't go the way it was supposed to go, but they don't speak up. And I want to go back to Kingston General Hospital and find out how they're doing. And one of the benchmarks for me will be the way they handle the next wave of comments, because there will be. Jim?
Yeah, I just wanted to comment that the Institute for Patient and Family-Centered Care had their international meeting on patient and family-centered care in Vancouver last summer. Kingston was one of the organizations that presented. There was striking interest from across Canada in the meeting that was going on. I thought some of the very important work I saw was coming out of the children's hospitals in Canada, which was very significant. We also saw some community-based work going on. There's also Russ Baker has just released a brief report looking at the correlation between patient engagement and improved outcomes. And then at the end of my talk, there's a hyperlink for those of you who don't know that publication towards recent report on that, which is both a Canadian as well as an international piece, as Ross is sort of used to doing. But what we heard out of the Accreditation Canada, what we heard out of Canadian Patient Safety Institute was a real drumbeat on this topic and a real feel for more and more content in this area, because there was so much interest in Canada.
Next from the floor, please.
Hi, my name is Michelle Stasiak. I am the co-chair of the Citizen Advisory Team here at South Health Campus in Calgary. I've been with that committee now for well over 7 years, since before the build of that site. So I just want you to know that if you don't believe this patient and family-centered care is happening in Calgary, it is happening in Calgary. I agree with the other lady that said, let's not do this work twice. Take what is learned at Kingston and learn from it. Come and have a look at South Health Campus and see what is going on there. I know there were presentations in Vancouver at the conference from staff at South Health Campus in the summer. So please, it is happening within Calgary, and I truly appreciate this new project, but let's not do the work twice. Let's learn from each other. There are many advisory teams and patients and family members on these advisory teams in this room. We don't need to duplicate. Thank you.
So I'll put in another plug for primary care along the same lines. At our clinic, we have patient advisory committees. We take the staff off-site for a day. And we bring patients and sit down with the patients and ask them about their journey and have our frontline staff, our physicians, sitting with patients to hear what their experience is. It's very powerful. It takes courage to do it, but the good that comes out of that, the understanding, can't be measured. So would certainly endorse the fact that there are some initiatives that are happening in our backyard.
Great. Just if you wouldn't mind, just to follow up, and I appreciate what you're saying. My problem when I started out is I didn't know anything. I just observed for 2 years. And then I tried to work in the system, and I found that I felt like there was too much inertia in the system for me to make a difference. Because I found that the system was initiating pilots and projects, and they were disparate. And my experience in business is if you need to make a big change, you have to come at it not with pilots and those sorts of things. You need to come with a broader strategy. And I have to say, I have met some people who have been engaged for years in this process, and they were very helpful as I worked with the folks in the O'Brien Institute, and they sort of helped us carry this forward. But it goes back to what I said earlier. The issue isn't our objective to be exclusive. It needs to be inclusive, and we need to learn from what others have done, and we need to build on those things as a platform. You know, hopefully that helps us get to better outcomes faster and make sure that there's common understanding. But my sense on a lot of these things, and I had my own experience this year, and I had wonderful doctors, but at one point I said to them, what happened to patient-centered care? And they said, what do you mean? We're patient-centered. And I said, you don't even know what the word means. And I said, I didn't say you didn't care about your patients, but I wasn't being included in the discussions and some of the things that were important to me. And so part of this is to make sure that we get to some common understandings, that we're talking about the same things, and that we make some decisions together. But we also need leadership, because it isn't going to happen just because we want it to happen. Somebody has to be at a point where they say, this is going to happen, and here's how we're going to do it.
I think one of the questions that comes out of hopefully today is how do we connect the dots so that others know where the pockets of really good care are occurring. We heard about one in the Unit 36. Why is that still just Unit 36? So yes, these things are in different places, but we need to find a way of connecting the dot and taking them throughout the province. That will be a huge challenge, but let's ask the question about how we do that.
I believe there's a question from Theater 3, so if you can activate the mic, please go ahead.
Hello, my name's Marianne, and I'm here on behalf of the Lyme Disease Association of Alberta. I'm a microbiologist, and I did submit my question also in a written form because it included some photographs, and a photograph is worth 1,000 words. I contracted Lyme disease in Connecticut or Rhode Island. I had a beautiful bullseye rash. I have DNA evidence that I have Lyme disease. I have PCR evidence and sequencing. I also had a biopsy and showed spirochetes in my liver. What we want to know, people with Lyme disease, is when can we have a dialogue at all? Right now, there is no dialogue. We bring our evidence to the table, it's ignored, and it doesn't matter what evidence we have, it's ignored, and we would at least like some dialogue happening. Thank you.
So if you have some license to rephrase the question a bit. So we are in an era where patients, the public, will come to the table with either experiential knowledge, their own review of science, literature, etc., and it sort of overwhelms the traditional way of doing things in a way, and it's certainly a new phenomenon. So anyone on the panel, can you tell us about how do you incorporate that? How do you establish a new kind of relationship where that is going to be a feature of the future much more than it is even now? Don't all leap at once.
I think that gone are the days when you can simply say, we've talked to our one expert, and our expert here doesn't think that there's any evidence that this happens or that happens or that, now it's an interesting dilemma when you have a small facility and the small facility can't be all things to all people. So you may have to develop lines of referral, but certainly at the very least, I think if you have patient and family-centered care, you bring people in, you have a conversation, you listen, and you find out what their needs are, what's their ask, and or asks, and go away and think about it, and not simply do a kind of a quick rebuttal and off you go. I listened to you, and therefore I've done my bit. That's my sense. Keeping in mind that Lyme disease is, there's some aspects of Lyme disease that are controversial, some are not. It may well be that particular institution, might be apt to say, well, we don't deal with it because they haven't delved in it. But they may discover that other institutions have developed expertise, and I think they have a responsibility to make that information known.
Yeah, and I think more and more, what resonates with me is the words of a mentor who said to me, a diagnosis and a treatment is really a negotiation between you and the patient. And you're bringing your facts and your medical experience to the table, but the patient is bringing their expertise as living in that body and their expertise of their community and of the knowledge that they've done. And it's really that collaborative approach and working together. And I think in primary care, we're taking more and more of that, approach. And ironically, it takes a lot of the pressure off us because we don't have to know everything. We're throwing on the table our perspective, and the patient is sharing theirs. And I think the decisions that come out of that are often much better. They are much better than us saying, this is what we need to do.
Yeah, I just want to comment. I've spent a fair amount of time in the last 6 months focused on veterans. Many of you may have known that we had a considerable issue in the United States about the care of veterans in the veterans hospital system, around scheduling, around delays, a lot of themes we've heard about today. What's striking is watching the healthcare system in the United States begin to come to realize that the veterans problem isn't just the problem, or the veterans' needs isn't just the needs for the VA system. It's for every hospital in the United States. And our old strategy, which we use very effectively, not my job, is being replaced by a huge focus on the care continuum. So today, as a trustee of a community hospital, for every patient who presents with an issue, whether or not it's something we have expertise in or not, we have a responsibility to help support the care of that patient to a place where their care needs can be met, as opposed to close the window and say, not here. And I think that's a huge redesign responsibility and leadership responsibility that we're all going to have to figure out, independent of whether or not it's something we do or somebody else does. We have a responsibility in service to the communities we serve to be able to answer that question, no matter how unique or how rare it is.
So, pardon me, I have a question through the Twitter feed. We've got several, but probably only take one right now. How does this UFC initiative integrate with the patient family-centered care strategy already in place in AHS? And I might, if I could, just slightly rephrase that to say, how does this citizen-led initiative that's been sponsored by the O'Brien Institute integrate with the AHS strategy?
I can't respond for AHS, but and I guess a little bit for the last question, the same thing. I think that person had a very specific issue, and somebody from AHS or somebody from the broader system would have to respond to it. And I'm not sure anybody sitting on the panel is the right person to answer that question. But hopefully there are people here, and if you persist, maybe you can talk to somebody. But as it relates to AHS, I mean, I am aware that AHS has a patient-first strategy, and it's well progressed, and they have some very good ideas. And again, it's no different than the response I had a few minutes ago. I would see that as a platform. My challenge when I think about AHS is it's only part of healthcare. It's an important part and it's an expensive part, but it's only part of the healthcare system that patients have to deal with. And some of the things that AHS might need to do, others need to do it as well. So how do we integrate those things, and how do we go further? Because, and I've had the pleasure of talking with Verna, you on the way through, and it's clear that in the process they did engage patients as well as providers in making the recommendations. But how can we go further faster? And so I don't see that there's a conflict in any of this. I think we're all trying to get to the same place. And it's how do we work together in doing that so that we can move faster, farther with more success. But as a patient and a family member of patients in the last 2 years, I have to say that my experiences didn't tell me that there was a lot of this going on. And that's why I got involved, and David's smiling because I'd say he's in the same boat. So how do we really engage patients and families? We've had a system where the paternalism in the system, which says the providers know best, has ruled for a long time. And providers have wonderful knowledge. But you know what? Patients have their own needs and their own uncertainties, and they can contribute to those decisions and discussions as well. And that's how I see the system going forward, to make it better. Not just to go to a provider and do everything the provider says without asking them any questions because they know best. Maybe there are things about me they don't know. Maybe my objectives are different than their objectives. And they ought to know that, and it ought to enter into their treatment.
There was someone's waiting here patiently.
Yes, my name is Anka Tuninger, and I'm just wondering how, you talked about inclusiveness. I also really appreciate the emphasis on dignity, respect, love, and that kind of background. That's what we need first and foremost, and I don't know how exactly they go about that in the system. But I was also wondering, is there any room in this system for complementary health, for the naturopath, for the Reiki, all of the other kinds of health that I know works, and what I found out that many of them use very much more this care system, because I could spend an hour or an hour and a half with my naturopath in order to look at and share, and I felt heard, I felt seen, I felt responded to. Is there room in our system for that?
So, Rick, you must have patients come through the door who are doing conventional medicine, may not be totally satisfied. How do you deal with this? I think that's the question. And are you comfortable incorporating it? Is it contingent, case by case?
Yeah, I just reflect on the journey in my medical home. And when I started 27 years ago, there was me and a nurse and somebody at the front, and that was the extent of our medical home. I now practice in an interdisciplinary team with 3 pharmacists, behavioral health consultant, health management nurses, respiratory therapists. So the medical home is broadening. We now have many more rooms in our medical home so that patients can access the right provider. I think the next wave in the evolution of the medical home is to bring those other voices in, and I think that's the direction of the future. I think the principle is that we've got to make that medical home the right for the patients who are accessing it.
Next. Whoever has a mic.
Hi, my name's Ian. I'm an ER doc. Thanks so much for everybody's stories and coming here. I have a couple of comments, and I want to give a bit of hope as well. Brian mentioned empathy gap, but what I've seen is an accountability gap. And on that line, again, physicians are paid a lot of money, and they're very good at doing procedures or doing the scope and doing the scan, et cetera, but a lot of them just aren't being patient advocates anymore, which troubles me quite a bit. And just as an when I work in ER, we all know the patient needs to come in, but nobody wants them, nobody's going to take them, and they think of reasons not to take that patient. They always want to pass it to another service, and that's the reality, and that's sad and that's disappointing, but that's the true reality in our system, and so that's where the system fails. But it gives me hope when Rick talks about team and collaboration and interprofessional, and I heard that. And just to give I'll just give you a real quick back. I mean, in the University of Calgary med school program, currently there's only 4 hours spent with other professions, other students, so they have no idea what the roles are, they have no idea what the other members of the healthcare team do. That's currently the curriculum, 4 hours of 1 billion hours. So we actually are making a change because we want people to work together as teams, and I think that's going to be one of our solutions to, obviously, and we all agree with that, is a team-based approach and not thinking of reasons to get rid of the patient, thinking of reasons to bring them into the fold. That's just my thoughts.
So let's maybe, because it is kind of critical for the position. We've heard today essentially a lot about it's baked into the system to be dysfunctional. We have a long history of how we have designed or not designed the system, and it gets in the way of people doing good and decent things. So where are we on the system redesign journey? I mean, you can have patients in all you want. You can be very inclusive, respectful, but if these kind of structural barriers, incentive barriers persist, it's going to be a long road to hoe. You've seen it in the evolution in primary care, that you had to move to a different mode of practice to get some of these things done. We've heard about this for a long time. So Deb, you wanted to leap in on this, and you've got a now system responsibility perspective too. So what do you think?
Well, you changed it just a little bit in terms of that. What I wanted to go back to and just capture around that team approach. And what I've heard is that providers struggle with the team approach and who's on the team. But from the patient perspective, we're told you're part of the team, but we're never introduced to who the team is. And I hear that through my work in my office is that people are left not knowing who the team members that they're working with are. So when we're talking about partnering, we need to be really clear about if you have a team, let's make it known who the team members are so that I can understand what my role is and what my part in that teamwork is. So I'm sorry, I changed it a little bit from the structure. I want to, if I could just say, I think that I've worked as a patient safety advocate for these last 9 years. And I think every person that I have ever met that has had an experience with an adverse event will come to the point of saying, I know that everybody goes into healthcare because of a passion to do care. What is it about their experience? What is it about our organizations? What is it about the system that erodes, destroys, and discredits that passion? So we need to find the ways of making sure that when you start your career, with excitement, enthusiasm, and commitment, you're ending your career with those same feelings and how we get past that. So that's one of the things is looking at how our organizations create the barriers.
Go ahead, Art.
I think one of the biggest problems of the so-called team thing heretofore is, I'm speaking specifically about family members, that they're simply not given the resources, and what for a family member being on the quote team really amounts to picking up various tasks that the medical services don't want to provide. And it becomes a kind of residual, you do everything else after this. And so the team becomes an unfortunate euphemism for laying things off. One of it would call for a whole separate meeting, but one of the crises of healthcare everywhere as the population gets older is how do you compensate family caregivers? Huge number of people, I'm sure many people in this audience, spend a significant amount of their time being family caregivers. How do you provide tax incentives for this? How do you allow people to take time away from their lives, their work, often give up jobs, to do something that the medical system simply has no capacity to undertake? That's an enormous discussion that has to happen. But for right now, the key thing is where responsibilities are being put on the family, resources have to go with those responsibilities. And the first resource that comes up crucially in our conversation today over and over again is having somebody to call 24/7. Having the kind of, what Rick means by the home, a crucial component is there's always somebody there who isn't just the impersonal health link. They really know your situation, and they're available all the time. A second thing that's been a persistent theme throughout the day is when family members flag a problem, the medical staff take that seriously. You go back to the digital stories today, perhaps the biggest common denominator in all those stories is Deb's story certainly exemplified this. We saw it. There was almost kind of a knee-jerk thing of the more the family flags something, the more the medical staff becomes resistant in an almost kind of perverse way to show that they couldn't be right. If there's one immediate thing that should be changed out of this, it's taking those family observations seriously. Pediatrics often does this. Pediatricians I've talked to for years they will acknowledge the validity of parental observations of the children. Why that doesn't apply to adult children about their parents, spouses about their adults, it seems to get lost in the transition from pediatric medicine to adult medicine.
So we've got about 8 minutes left. So Brian, you want to get in quickly here? Then there's a question in Theater 3, and if we have time, we'll do one more from...
Yeah, just a real quick observation about some of the last two comments. I think a lot of institutions claim to have a team-based approach, where if it happens, it's more of a coincidence or more of a temporary entity. Wow, that team worked. Wouldn't it be nice if we had this all the time? So I think you actually do have to restructure. Somebody has to say, we're going to have this team-based approach. This is how you guys are going to organize yourselves. Do it with input. Don't just impose it from within. Once you do that, you have to, part of that team-based approach is figuring out who does what. Who is the first person you call when you need care? When you have a crisis or when something's happening and you need to re-enter the system? And once you've done that, now you can begin to understand where the family caregivers might fit in that framework, but not make it up as we go along ad hoc. This is what you're going to do, or these are the things you could do. Maybe this is the extra thing. These are the extra costs. How are we going to work this out so that we have continuity of care and you don't ever feel abandoned? But to do that, you have to not only change, you have to create that system, you have to change the culture to be able to do that. And one other random observation that I want to make: you cannot graft patient engagement onto a dysfunctional system and expect it to work. Sorry, you can't.
All right. Thank you. Okay. Theater 3, please. Go ahead.
Yes, I'm Kathy Graney, and I have a question. It's a two-part question, and it's about the government and how we can affect some change. When the Conservative government of Alison Redford in this province set up or announced that they were going to set up primary care networks some time ago. I believe they arrived at a number of 140 primary care networks that they were going to set up. And I was wondering if anyone knew how that number had been arrived at, what was used as the criteria for deciding on that number. And I want to know what the panel members feel about the possibility of affecting change with the present provincial government that we have here now, seeing as we don't seem to have any effective opposition, and that there's probably going to be talk, and there is, of impending budget cuts, and how that's going to affect our health care with the present situation that we're facing in Alberta.
I could speak briefly to the family care clinics, and I think to be positive about that experience, what it brought to light in primary care is that medical homes have to look different in different communities. And we've, and a shout out to some of the people in this room, from Alex, from CUPS, from the FCC and Northeast Calgary, who are finding a different structure to deliver care to patients that have different needs than the patients are in my neck of the woods. So I think that was the gem that came out of that, and I think there's some really more exciting things down the road.
Well, I'm assuming the rest of you don't want to do a complete political analysis of the prospects for change under various regimes.
I will say, though, that the Alberta Health Advocates Office is almost up and running. We've been working on it for the last 6 months to get it up and running. We do have a health charter in the province. We're the only province in Canada, so we are moving ahead with that. It will be my position to implement that charter, to have the conversations. It aligns very well with the discussion that we're having today. So I think that will be a piece of the puzzle going forward. I'm hoping so anyway.
Just 1 minute, and I'm not going to speak on behalf of the government. But I will say the whole point of this launch today is to engage Albertans in a discussion about the kind of change we'd like to see. And so from my perspective, the more Albertans that get involved and share their expectations and their experiences, good and bad, like, let's not throw the baby out with the bathwater. Let's build on what's going right, and let's find ways to make other things better. And if we can do that, and we can make good recommendations to a government, I believe the government will be listening, because they're looking to do exactly the same thing I think that we're trying to do.
30 seconds.
The brief thing I would add is a situation of budget cutting, which is what we all are looking, I mean, it's the elephant in the room, is that everybody knows the provincial budget's going to get cut. It's a wonderful opportunity for renegotiating a lot of long-standing turf allocations and who's responsible for what on what basis. Because a lot of things are going to have to change. It's a moment when anything can change. And in terms of groups that have blocked the recommendations of the Flemings report, that are not going along with these things, this is a golden opportunity for the political leadership of the province to negotiate the relationships between the major partner groups that often don't partner, and create a new sense of interprofessional responsibility spheres.
We got time for one more quick one from the audience. I don't know who.
I check. I had a question about it's an A and B part question about the interface between an interdisciplinary team approach and person-centered approach, and the interface between clinic policies and person-centered. Like, I'm a citizen and entrepreneur, but I've had a lot of issues, and all of them have said I'm too complex and stuff like that. And I had a complex care clinic meet without me. I thought that was a violation of my rights, so I had to fire that doctor. But I was wondering the interfaces between all those.
Yeah, I think your comment points out the fact that we need different kinds of medical homes for all patients. I think that the comment about putting a bunch of people together in a room and saying you are now a team is what we've often done. And as one of my nurse mentors reminded me in my early days, a few years ago, Rick, being a medical team is not you telling everybody what to do. So I think we're evolving in terms of what an interdisciplinary team looks like, and I think that probably the icing on the cake is going to be, once we get our act together and can play in the same sandbox, is finding the right place for patients, and that's going to vary in the medical homes that we're creating in the province.
Well, with that, unfortunately, we are out of time. I want to thank the audience for your great participation in this, and thank the panelists for your responses and interactions. So we're just about at the end, and panelists, if you like, you can stay here for the final 10 minutes to listen to Tony and Bill, but it's entirely up to you if you want to find a thing there. So are we going to get a podium back for Tony? Yes. So while they're doing that, let me introduce him. It's my pleasure to introduce Dr. Tony Fields. He's the board chair of the Health Quality Council of Alberta, professor emeritus of oncology at the U of A. He is one of the great gurus of cancer care in the province. Again, he is a much honored physician, including a member of the Order of Canada and the inaugural Minister's Award for Outstanding Medical Services from Alberta Health. And in 2005, he was named one of Alberta's top 100 physicians of the century. So please welcome Tony Fields.
Thank you, Stephen. And I really have to offer my thanks to the organizers for inviting me to come all the way from Northern Alberta to have the privilege of participating in this incredible, moving event that we've had today. There was such a richness of experience, such a wealth of ideas, and so many glimpses of potential solutions and directions that have been offered today. It's really difficult to know where to start. It's also going to be difficult for me to know where to stop, because so many of the experiences and so many of the little glimpses that speakers gave us reminded me of things that I myself have witnessed, had participated in over time. Even something like the terrible shock to a family in the emergency room. When someone has died, I was rocketed back to when I was an intern in the 70s at the Royal Alex, and I was assigned to the ICU, CCU, and the two interns assigned to that were the ones in charge of the codes. So it was when we arrived at a cardiac arrest code, we were the ones empowered by the director of CCU to manage the code and to say when it was enough. And there was this woman who was brought in arrest, and we fought and fought and fought, and it was going, and finally I had to say no. And then, just as we heard from Brian, I felt it was up to me then to tell the family, and I went, and there was her daughter and her daughter's husband. And so I, as gently as I could as an intern, I explained. And the daughter collapsed like a puppet. Strings had been cut. I had actually caught her. And her husband explained that she had emigrated, the daughter had emigrated from Poland 20 years ago and had not seen her mother for 20 years. Her mother had just flown into Edmonton to see her, stepped off the plane and collapsed. Now today we would know that probably had a massive pulmonary embolus, but I just remember that incredibly overwhelming feeling, and I had to stop myself from saying, just wait a minute, let me go and try some more. which, so that was, and I could tell story. I know one of my colleagues said, Tony, not another anecdote, please. I could tell stories all day, and I may tell another one at the end. But I did want to touch on some of the things that we heard. Those patient stories are so gripping and so powerful. And one of the things that Brian said about defensiveness, we who are in the system here have to, because you're part of the system, there's a sort of an instinctive reaction to defend. Well, these are outliers, or well, this student, so. But you have to, exactly as he said, for a single person, you have to sit back and listen. And Stephen and I had an aside conversation and said, well, whereas we know, of course, that there are so many excellent examples and so many people are well served by the system. However, if this is 2% or 5% or 10% or whatever percent of patient experiences, it's not acceptable. We have to get better. It's that simple. So you have to listen, you have to learn, you have to turn things around. I heard so many other rich little things, the linearity of the system. And we heard from Charlie how, we heard from our dean, John, and we heard from Charlie, we heard from Dave about the linearity. It's like a relay race. And that's why if you ask one person, they'll say, well, I mean, I'm patient-centered, and I see my patients, and I deal with them. But all of the going from pillar to post, it's there may be a shortcut from the start to the end, but you have to go through this relay race. And the terrible tragedy in the story of Greg Price is that the baton was repeatedly dropped and left on the ground during that relay race. And so we have to think of that is a provider-centric system, without question. I loved the talk about the empathy gap, and it was to hear about the late, great Dr. Robert Buckman. I learned so much also from Robert Buckman, and he taught me I remember one little thing, and because it came back to me in clinic one day, here I go with another anecdote. But he said, imagine you go in to see a patient, and the patient says, look, you've kept me waiting 10 minutes. Well, I thought of my own clinics, 10 minutes? I said, you are upset because I kept you waiting 10 minutes. Don't you know I saw a woman yesterday who delivered a baby when she was waiting to see me, and she wasn't pregnant when she arrived. But the point about patient centricity is that 10 minutes is important to that patient. And you have disturbed that patient's equanimity and misserved that patient with that 10-minute wait, regardless of what your median and average wait times in your clinic are. The issue of the empathy gap, so incredibly important. And there are positive things in this. And having heard this story from Jim and from Deb about the mishaps, I remember at the Cross Cancer Institute our own dreadful mishap in 2006 where a patient died because chemotherapy infusion was given over 4 hours instead of 4 days through an error in programming an ambulatory pump, and she died. Now, I won't go through. I'll just try and project you into 3 days after the patient's death. Imagine at the peak of the grief, the hurt, the intensity, all of the emotions. And I met with the family husband, brother, and sister on behalf of the entire Alberta Cancer Board. And it was 4 hours with the family. But it came up, and I don't have the time to explain how it came up, that they expressed an interest in going to meet the nurses in the daycare unit. Now, the nurses who had been involved in the incident were on the compassionate leave. We were supporting them through our psychosocial department, but they wanted, and I thought, well, let's try it, sort of. That was my, and so I nipped down to the unit and asked the nurses if they would be up to this, and they were scared like anything. They said, "Is it going to be all right?" And sometimes as an administrator, you bluff. And I said, "It'll be all right because I'll be here and I'll keep it safe." How am I going to do that? And I went back up to collect the family and bring them down, and they asked me if this was going to be all right. I said, "It'll be okay, I'll be there and I'll keep it safe." But you heard about the talk about why people get into going to healthcare because of their passion. And you heard about the sort of barriers that can build up. Well, I want to project you into that room with these 3 family members and about 10 nurses. And it was one of the most intense emotional experiences of my personal or professional life. And to see them expressing to each other, the nurses expressing their sorrow, they're apologizing, the family saying that this was an accident. The expressions of sorrow from the staff and the incredible response of the family and their capacity for understanding and forgiveness. And everyone hugged everyone else, and everyone cried except me, because I felt I had to try, and it was difficult to hold it together, Kleenex going around. And so you see that, and you realize there is hope in terms of people, so why can't we build on little things like this and build on those feelings? And why can't we diffuse this out? I think it was, it may have been Charlie, now I did jot this down, who had talked about the importance of empowerment and making staff feel that they are valued, the organization values what they do, the organization counts on them to do their best and even more. The organization values it. If you could imagine the power of Alberta Health Services, 110,000 physicians and employees, and if you could make every one of the 110,000, I actually said this to Dr. Duckett one day when I came late to a meeting, and he asked me something about why the staff satisfaction was so, what do I think? And this is what I told him, and he threw not a cookie, but a chocolate at me. But if you could make every one of the 110,000 feel that they were counted on and that they were valued, you could move the Earth in its orbit. So I digress. So much richness, the concept of that Art brought up, the low bar versus high bar, the 4 principles, the reciprocal benefit. And I strongly believe, and we heard it from Art, we heard it from Jim, and I strongly believe it, that truly patient-centered care is going to be better care, and it's going to be cheaper care to the system as a whole. I touched on, and Art, you are the one that first brought up the making people feel appreciated, perhaps. The principles that Jim brought up, dignity and respect, information sharing, participation and collaboration, and we've heard so much about those. I'm not going to go into them any farther, but I'll come back and touch on them. And Charlie reminded us of our system or non-system, that it's not just AHS, that it's AHS, it's primary care, it's continuing care, it's public health, and you could go on and on. But so are we going to feel to bring up that we can't boil the ocean? Well, I'm sorry, you can boil the ocean. If that's how you describe the task ahead, you can do it. Monday was Martin Luther King Day, Monday this week. And look at the power of grassroots movement. Look at that. I mean, and there was a marginalized, substantial but marginalized minority. And look at what they were about to achieve. And we shouldn't say that, well, AHS is doing it, and we at the HQCA have a patient family safety advisory council, so there shouldn't be a citizens movement. Of course there should be. One of the things that we've learned about dealing with these complex systems is we need a lot of redundancy. We need overlap. We need repetition. So yes, let's do it, because citizens means all of us. It means everyone in this room. It means everyone who has been, or could be a patient. And we actually do have power. So I really encourage this movement to imagine, vision, describe what you would like, and inspire. And if this movement spreads, we will actually have enough momentum and enough power to be able to empower those in the system and force them to enact progress towards the vision. Now, lastly, I will say, what about Health Quality Council? Now, and so I'm going to just talk briefly about quality. We look at quality through the 6 lenses, as it were: accessibility, acceptability, appropriateness, effectiveness, efficiency, and safety. The first 3, accessibility, acceptability, and appropriateness, elements of patient-centric care are distributed through those. We politically and through the media and tend to sort of focus down accessibility, and we think of time. Or if we think really hard, we think of geography too. But there's much more than that. Is something accessible if it's not spoken, and if you can't access it in your language, if it doesn't suit your culture, and appropriateness? I mean, there's so much potentially richness in terms of patient centricity in appropriateness, and efficiency. And you will say there may be some friction between these others and efficiency, but I come back to that statement that if we have truly patient-centric care, it's going to be less expensive, more effective, and therefore it's going to actually improve efficiency overall. So what's the message for us in the council from today that I will, when I'm next meeting with the board, what am I going to bring up? It is for us to look at those lenses, particularly those 3, and ask if we are paying enough attention to patient centricity in those. You know, we tend really to look at the what's, where's, when's, even why's, but so much about patient centricity that we've heard about is about how. And are we putting enough how into the lenses that we examine the quality of care from. So let's go out and start inspiring, but I have one final message because I can't take my cancer hat off, and I'm not going to use the word cancer, but in much of what I did with cancer, trying to improve the lot of the unseen patient. That includes the patients of tomorrow and the day after and our children's generation and so on. If we are building momentum towards the grail of patient centricity, let's not forget the power of citizenry. You know, another way of looking at this is, we talk about the health system often as if it's them and it's us, but it is our health system. We are citizens, it's our system. We have a responsibility and an obligation to it. So that's one of the other reasons that this movement resonates with me. While we're doing that, let's find time to step back and look at health in a broader way. And maybe we can actually come to look at prevention, wellness, and activities like that. And think of the gift that we could give our grandchildren's generation if we could find the time and the energy to look at wellness as well as care. So I'm going to stop, but thank you again for inviting me to this wonderful day.
Our former dean, Tom Feasby, doesn't let us shake his hand either, so you're not. Thank you, Tony.
Your current dean and I share an interest in gastroenterology, and he suggested that we greet with the way a gastroenterologist would, and it's not analog.
All right. Well, I'm going to keep my closing comments very brief because I think Tony put a wonderful wrap on the day in terms of some of the concepts. On behalf, I'll begin just with a few quick operational announcements and then just a few closing thoughts. The announcements are to say that there is a reception in the atrium, so there is an opportunity, which is down the stairs, where you registered, so there's an opportunity to network and to interact with some of the speakers. So please stay if you can. The second is to say that the Imagine project is meant to be longitudinal. As we've said today as a beginning, do use the email, which is a Gmail address up on the screen. And that other thing, because my team knows an inside joke that one time I referred to the hashtag as a number sign, and everybody younger than me laughed at me. So hashtag, and if you're really cool, you say that. Because that's the way to bring your ideas forward. Know that this is meant to be a conversation and that we are in a province where there is innovation. We heard about the different sectors, that there's the AHS visions that are in place and programs that are in place that we really want to link to, and we want to bring the voices to those initiatives, and then also link to the primary care sector and other portions of our healthcare sector. Somebody made a comment about complementary therapies, integration of care. So we have a context. There are a number of thank yous, too many to mention, except that I do want to, of course, thank all the speakers. I want to thank Charlie for his initiative brought to our School of Medicine. And I need to thank Ward Flemons. He's not the reason we call it the Ward of the 21st century, but Ward has been the chair of the planning committee for today, and I think you've seen an incredible event, incredible hours by Ward in preparing this. And I want to thank the citizens group, so Citizens Impacting Healthcare in Alberta, who have contributed to our planning and so many of the ideas today. I'll just close by saying I was very worried about today, like really worried, because I knew we were bringing difficult conversations out. And this mention of empathy is important because obviously as citizens, we listen to those stories. Greg's story is gut-wrenching, Dave. So I found that very hard to listen to. But so that it was hard on that level. Is it healthy to hear those stories? It's healthy for all of us to hear those stories because they're challenging. I also worry about the healthcare providers who are in the room listening, of which I am one, because some of the things we hear sting, because we know the stories are true. We know that some of the experiences are terrible, and we have to ask ourselves the tough questions that Brian raised about why is it this way, and it's okay to stir up emotions. I think we then have to find a way to package them up and put them back in a box that we can work with. So some of you may feel a little raw after what you've heard. And then I also worry about the friends and colleagues that I admire who are decision makers in our healthcare system, because they work unbelievable hours. They get fired when governments find it convenient to fire them. I worry because they're working tirelessly for us, and it's hard to hear some of this. So as we walk out, that's that empathy, but bi-directional empathy, Reiser's law, bi-directional Reiser's law. Just try to take communication, respectful communication, constructive communication away from today, and then hopefully come up with ideas where we have dialogue and engagement. So with that, I'll end the day, encourage people to network, go downstairs to the reception. The last thing I'll mention is that through the exciting preparation of the Imagine Project, one of the key features of the Imagine Project is that we have a dinner tonight, and it's a by-invitation stakeholders dinner. And we are pleased to be able to let you know that the Premier and the Health Minister are both coming to the dinner this evening to continue this dialogue, along with a number of community leaders, leadership in the AMA, many other groups, the Health Quality Council, Alberta Innovates Health Solution, other representatives in government. So an opportunity to bring this dialogue to our provincial leaders and put it on the radar screen. So more to follow. Thank you to all of you, the audience. It's been a long afternoon, a bit of a draining one. Have a good evening.